Good morning. Good morning. Good morning. A very, very warm welcome to everyone here this morning. Of course, we have persons in attendance, so very warm welcome to you. And indeed, we are very happy to see persons face to face again. This has been a long time in coming, and this would be our first face to face since the pandemic. And of course, we're accustomed to persons being online, so happy to have you as well. Now, my name is Nakero, and I'm a Sandoz medical representative, and I will be your moderator for today. And of course, we have a team of excellent Sandoz representatives, and I will want them to introduce themselves. So they're sitting there at the back. So if you can stand and introduce yourselves. We want everyone to see that it's not just me here. Yes, I'm sure the camera is going around that side. Yes, yes, thank you, thank you. So indeed, we extend our appreciation also to Pegasus Hotel for hosting us today. And we appreciate you coming online on time. So before we get into it, I'll invite Mr. Wayne Young to come and do a prayer. Mr. Wayne Young, you can clap him.
All right, thank you, Mr. Rowe. All right, for those of us who are here, we'll just assume a reverent posture as we pray. Dear kind, loving, and compassionate Father, we thank you once again for spirit lives. We thank you for allowing us to come here in this fashion physically. We ask that you may hasten the footsteps of those who are coming. Help that today's proceedings may be one of success, and that at the end of it, we'll all go home safely. Please bless and keep us both individually and collectively. In your son's name I pray. Amen. All right, so we just had our prayer. Let's have our official welcome. Just to make this official, Mr. Rowe did some of the welcome earlier. However, on behalf of our Senior Executive Committee, or First Line Manager, Mrs. Nikisha Blake McFarlane, and by extension, the Sandoz Jamaica team, welcome. Welcome also to our many registrants who have logged on online. This is our first hybrid, as Mr. Rowe had mentioned earlier, since 2019, pre-COVID era, and it promises to be an interesting one. We have 4 speakers with very pertinent topics lined up for us today. So please sit back, relax, and enjoy. Have a great day. At this time, we'll have a video presentation. Thank you.
So we are about as ready as we can get. So without further ado, I will invite Mr. Javan Cameron to come and welcome our very first speaker for this morning. Please make him feel welcome.
It is a pleasure this morning to introduce our first speaker, who will be speaking to the topic, Management of Complicated Sinusitis. A graduate of the Holy Childhood High School for Girls, then the University of the West Indies, Mona, Jamaica, where she achieved her Bachelor of Medicine and further specialization in the field of otorhinolaryngology, followed along with other educational achievements such as a diploma in Spanish and a certificate in university teaching and learning. Her surgical training spanned various hospitals. Locally, she practiced at the St. Anne's Bay Hospital, the University Hospital of the West Indies, the Kingston Public Hospital, the Bustamante Children's Hospital, and internationally, Royal Marsden Hospital in Chelsea, London, and an observership at the Hospital for Sick Children in Toronto, Canada. Implementation and techniques for growth is continued through the American Academy of Otorhinolaryngology, Head and Neck Surgery, among other international and locally acclaimed associations. Our speaker belongs to the cohort of several medical professional bodies and maintains active membership with various medical and surgical associations. She has made and continues to make significant contributions to the development of healthcare locally and serves as a role model for numerous medical students under her guidance. Ladies and gentlemen, please welcome to the platform Associate Lecturer at the Department of Surgery, Faculty of Medical Sciences, University of the West Indies, Consultant and Head of Department of Otorhinolaryngology Surgery at the Bustamante Hospital for Children, Dr. Marsha James.
Good morning, everyone. Thank you so much for that glorious introduction. Thank you, Sandoz and Association of General Practitioners of Jamaica, for inviting me to speak this morning. And thank you to all persons who have come out this morning so early to hear my presentation. All right, so this morning we're going to be speaking about acute and chronic sinusitis, specifically complicated sinusitis. And I decided to choose this topic because of some of the cases that I've seen at Bustamante Hospital recently. Just having the technical difficulty. All right, so from the beginning, today we'll speak about the management of complicated sinusitis. This is my disclaimer slide to say that the opinions on these slides are all mine and not of Novartis, and that there's no conflict of interest. All right, so before I begin, I want to do a quick Zoom poll for those who are online, and for those who are present, you can articulate your answers. So approximately what percentage of the patients that you see in your practice monthly require treatment for sinusitis? Dr. Chen? Yes, of course. Dr. Chen is an ENT surgeon, one of my mentors. Anybody else? How many patients do you manage for sinusitis? 10%. Thank you, Doc. Anybody else? No?
All right, so we're ending the poll now. About 39% said less than 25%, and 30% said 25%.
Okay, so actually sinusitis is pretty common, and I'm surprised that you're not seeing more patients. Okay. All right, so the objectives of my talk today, sorry about the clicking back and forth, will be to recall the basic anatomy and physiology of the paranasal sinuses, to define acute and chronic sinusitis, to ensure that you're able to recognize some clinical features of complicated sinusitis, and to discuss the management of complicated sinusitis, as well as discuss the role of antibiotics in the management of sinusitis and complicated sinusitis, and to identify indications for surgical intervention in patients with complicated sinusitis. So the paranasal sinuses are outpouchings of the nasal mucosa. They are paired structures. So you have the frontal sinuses located in the frontal bone, the maxillary sinuses, which are the largest ones located in the maxillary bone. The ethmoids are complex of labyrinthine sinuses within the ethmoid bone. And then you have the sphenoid sinus, which is located more posteriorly. The ethmoids and maxillary sinuses are present from about 4 months of gestation. So they're present at birth, and then the frontal sinuses and the sphenoid sinuses pneumatize later. So these are CT images showing the sinuses. You can see in the coronal image, the inferior turbinate, which is the largest one at the bottom, then the middle turbinate, the anterior ethmoid, the maxillary and frontal sinuses drain into the middle meatus at the osteomeatal complex, which is a very important structure in development of sinusitis, while the posterior ethmoids and the sphenoid drain into the superior meatus. So a lot of patients will ask, what's the function of the sinuses, especially when they're plagued with sinus symptoms? But the sinuses have been found to be important in humidification and warming of inhaled air that reaches to the lower respiratory tract, as well as important in the filtration of inspired air to remove particles and microbes. It's also thought to be important in increasing vocal resonance and insulating structures such as the dental roots and eyes from rapid temperature fluctuations in the nasal cavity. They're also important in reducing the relative weight of the skull and acting as a buffer against facial trauma. The paranasal sinuses are in immunological defenses, both adaptive and innate. The sticky mucus will capture microbes, as well as nasal dendritic cells will present antigens to T cells. One negative aspect of the paranasal sinuses that came out during the pandemic, the COVID-19 pandemic, is that this was a common site for the virus, and it actually promoted viral proliferation. So how do we define rhinosinusitis? So rhinosinusitis is a group of disorders characterized by inflammation of the mucosa of the nose and paranasal sinuses, and complicated sinusitis is the orbital or intracranial extension of acute bacterial rhinosinusitis. is via arbitrary duration that was decided on by several bodies, including the American Association of Asthma, Allergy, and Immunology. Acute sinusitis lasts up to 4 weeks or 30 days with total resolution of symptoms between episodes. Subacute sinusitis persists for more than 4 weeks, but less than 12 weeks. So that's like between 30 to 90 days with total resolution of symptoms between episodes. And then chronic sinusitis in 12 weeks or greater than 90 days with persistent signs and symptoms. And recurrent acute sinusitis is 4 or more episodes per year with complete resolution.
All right, sorry about that, gents, people. Morning, morning, morning. Seem to be having a bit of Murphy Law. So, that looks lovely. Check, check, check. 1, 2, 1, 2.
All right, thanks. Everybody hearing me now? Okay, great. All right, so one of the important things to remember, in acute rhinosinusitis, this is usually related to infection, mainly viral, and it is important for you to note acute bacterial rhinosinusitis because this is what is associated with complications. While chronic rhinosinusitis is usually related more to inflammation, but will have exacerbations of infections, episodes, of course. All right, so the epidemiology of rhinosinusitis, about 7.5% of upper respiratory tract infections are complicated by acute bacterial sinusitis, and about 10% of children by age 3 will have an episode of acute bacterial sinusitis. So it is important for you to look out for these patients and to be able to make that diagnosis. The average age of diagnosis is about 18 months. Girls are more frequently affected by acute bacterial sinusitis. And the literature has shown that 1 in 8 adults in the US is affected by acute sinusitis. And it's one of the conditions for which antibiotics are most prescribed, sometimes inappropriately, again, interfering with our antibiotic stewardship and contributing to antibiotic resistance, because studies have shown that patients, they benefit from prescribing antibiotics for patients with acute rhinosinusitis. The difference is minimal, about 5 to 6%, because most of the underlying causes of acute rhinosinusitis is viral. Complicated sinusitis is more common in adolescents and young males. So pathogenesis sinusitis results from a myriad of factors. So there's mechanical obstruction of the drainage ostia. So remember, we spoke about the osteomeatal complex. There is also the impact of impaired function or reduction of cilia, and this is further impacted by mucosal thickening, usually from negative pressure from obstruction of the ostia and oversecretion of thickened mucus. 63% of cases of acute rhinosinusitis, bacteria that are most commonly implicated are 3 main ENT bacteria, so Streptococcus pneumoniae, Marxella catarrhalis, and Haemophilus influenza. And with immunization, we have seen some reduction in the presentation of acute bacterial sinusitis. For complicated sinusitis, Staph aureus, including methicillin-resistant staph, as well as Strep pyogenes, E. coli, Klebsiella pneumoniae, are among some of the polymicrobials causing this condition. So there are several factors, both local and systemic, that contribute to the development of rhinosinusitis. So the presence of allergic rhinitis, so patients with atopy or patients diagnosed with allergic rhinitis have a 4-fold risk of developing acute rhinosinusitis. So it's important that you recognize and diagnose your patients with allergic rhinitis and manage them appropriately to reduce the incidence of acute rhinosinusitis in these patients. Upper respiratory tract infection, about 70% of them can be complicated by acute rhinosinusitis, and then patients with anatomic abnormalities, deviated nasal septum, abnormalities within the middle turbinates or within the ethmoids, patients who have nasal polyps. In our pediatric patients, foreign bodies can cause mechanical obstruction and increased secretions, trauma including barotrauma, and of course smoking, both primary and secondary exposure to smoke impairs cilia movement and filtering and clearing of particles from the nose and paranasal surfaces. Overuse of topical decongestants as well can cause hypertrophy of the inferior turbinate, causing obstruction to the ostomeatal complex, and these agents are usually available over the counter, so your Atrovine and your Afrin, and patients tend to abuse this because they do get immediate relief, but not usually long-lasting. There are other systemic factors that you should consider, so patients with immune deficiency, patients with any ciliary disorders, and gastroesophageal reflux has been shown to increase the incidence of acute rhinosinusitis as well as chronic rhinosinusitis, threefold. So if you have patients with gastroesophageal reflux, you should manage this as well to assist them in the management of their rhinosinusitis. So the JACI, that is the Joint Task Force of Allergy and Immunology, came up with some major and minor symptoms that could be used to diagnose acute rhinosinusitis. So the diagnosis of rhinosinusitis is mainly clinical. So you have to have a high index of suspicion, and you have to take a good history and detailed examination. So the major symptoms are anterior or posterior purulent drainage, nasal obstruction, congestion or blockage, facial pain or pressure, hyposmia and nausea, and acute fever. Minor symptoms, they considered headache, ear pain or pressure, halitosis, dental pain, fatigue, and cough. So even though headache was considered one of the minor symptoms, this is something that you should look out for, especially in patients who may be at risk of complicated sinusitis. So headache is not something to be dismissed. You should explore what is happening with the patient who presents with headache, especially if they have other neurological symptoms. The European paper on rhinosinusitis suggests that the presence of 2 or more nasal symptoms along with any other symptom can also be used to make the diagnosis. Acute rhinosinusitis has several causes. We spoke about infections, mainly viral, and then acute bacterial infection. There are also environmental irritants, so it's important for you to speak to the patients about these and how they can avoid and do lifestyle modifications to manage that. And then there is allergic rhinitis, which we said increase the risk 4-fold. So acute bacterial rhinosinusitis is what is implicated in the development of complicated sinusitis. And it's important for you to recognize these symptoms. So patients may have persistent symptoms, usually greater than 10 days. So if patients are still having severe symptoms or moderate to severe symptoms after 10 days, your index of suspicion should be heightened. Patients may also have what we call double sickening or biphasic presentation. So they start to improve and then they start to get worse again. Persistently high fever, persistent postnasal drip, and headaches and any other neurological symptoms should be considered at this time. So what are some of the complications of rhinosinusitis? So the most common complication, usually orbital complications, and this is most common in the pediatric group. So about 60 to 80% of complications of rhinosinusitis are orbital complications. Intracranial complications account for about 15 to 20%, and osseous complications about 5%. So your intracranial complications are both suppurative and non-suppurative. So meningitis is a fairly common presentation. The presence of any intracranial abscess is an emergency and requires immediate treatment and usually surgical intervention. Cavernous sinus thrombosis presents with the greatest morbidity and mortality. So these patients present with proptosis, ophthalmoplegia, severe headache, and usually worsening visual loss. It may be unilateral and then spread rapidly bilaterally. Osteomyelitis of the frontal bone can occur with frontal sinusitis and the presence of a soft swelling over the frontal region, described as a Pott's tumor, requires as well usually intravenous antibiotics and surgical intervention. And a lot of our patients are atopic, so patients with rhinosinusitis may also have exacerbation of their asthma, and this needs to be addressed. So what are some of the clinical features of complicated sinusitis? So our pediatric patients usually don't present typically, so they may be actually very quiet or silent. Usually they are not verbal, so sometimes difficult for them to express what is happening, but it's important for you to pick up on some of the signs and symptoms. So periorbital swelling is usually one of the common presentations, a frontal swelling as well should clue you in. If they have high-grade fever that's not responding to your antibiotic therapy and antipyretic therapy, if there is any change in conscious levels, lethargy, and nuchal rigidity, then this should clue you in to require further consultation with a specialist team, both ENT and neurosurgery. And any patient with seizures or hemiparesis requires immediate attention. So because orbital complications are one of the most common presentations, we just wanted to go a little bit into the classification. So Chandos classification is what is normally used, and it's a group of conditions. So group 1 is preseptal cellulitis, which is inflammation and edema anterior to the orbital septum. Group 2 is orbital cellulitis, where it extends to include orbital contents posterior to the septum. And group 3 is subperiosteal abscesses, and this is where we normally come in as ENT surgeons. So the management of subperiosteal abscesses is a bit controversial because we are taught that the management of any abscess is incision and drainage, but with the advancement in antibiotic therapy, patients, especially younger patients less than 9, have been shown to show improved clinical outcomes with high doses of IV antibiotics. But group 4 and 5, orbital abscesses and definitely cavernous sinus thrombosis, these require surgical intervention. So again, remember the diagnosis is mainly clinical, so remembering your symptoms and signs by doing a good detailed examination and history taking. Nasal endoscopy can show you the nasal cavity, the osteomeatal complex, and also exclude any other causes of nasal obstruction. CBC, CRP, and ESR can also be helpful. Elevated white blood cell count with neutrophilia, elevated CRP and ESR can also clue you into acute bacterial rhinosinusitis. CT scans are not routinely required for acute rhinosinusitis, but if you suspect that the patient has acute bacterial rhinosinusitis that is complicated, then a CT scan is indicated. Any patient with periorbital presentations or intracranial complications require CT scans. MRI are complementary to highlight the soft tissue changes. Nasal swabs are usually not recommended. They're usually not helpful because they don't normally represent what is happening in the sinuses. And actually the gold standard for culturing the sinus is doing an antral puncture, which is not something that we recommend. So here in the CT images, if you can look carefully, I'm sorry, I don't have a pointer, but on the left side anteriorly, you can see collection near the frontal bone, and you can see thickening of the mucosa within the frontal sinus on the image on the left. So because the patients present with vague symptoms, sometimes nasal obstruction, I know that you're tempted to say, oh, sinusitis is common in sinus, and the patients will say, oh, I have bad sinusitis. But you also need to remember there are other causes of nasal obstruction that you may need to exclude. So patients with persistent symptoms or worsening symptoms, you should suspect sinonasal neoplasms, both benign and malignant. You should also look for nasal polyps. So patients with chronic rhinosinusitis can present with or without nasal polyps. Patients with nasal polyps will require management by ENT and may require both oral and intranasal corticosteroids. Patients with persistent headaches, you should investigate them to rule out intracranial tumors, and if they have nuchal rigidity along with acute inflammation, you should think about meningitis, and of course, foreign bodies in our pediatric patients. So the definitive management of complicated sinusitis includes both medical and surgical management. There's criteria for medical management and surgical management, usually for group 4 to 5 orbital complications and all intracranial complications. So this is an algorithm from the Academy of Otolaryngology Head and Neck Surgeons. So it looks at the management of adults with sinusitis. So they considered patients with acute rhinosinusitis and patients with chronic sinusitis. And if you notice in the acute rhinosinusitis, they consider patients with acute bacterial rhinosinusitis because these patients are at risk of complicated sinusitis and may require further imaging as well as intravenous antibiotic therapy or surgical intervention. Patients with chronic rhinosinusitis, usually this is more related to inflammation. They may benefit more from medical therapy and allergy testing. So antibiotic therapy is indicated in patients with acute bacterial rhinosinusitis, patients with infectious exacerbation of chronic rhinosinusitis, patients with persistent symptoms, usually more than 5 to 7 days, will benefit from antibiotic therapy. Corticosteroids, both oral and intranasal, are useful in patients with chronic rhinosinusitis. Decongestants and mucoevacuants are useful for symptomatic relief, as well as antihistamines for patients with underlying allergic rhinitis. Non-pharmacological treatment, especially normal saline irrigation and rinses, have been found to be very beneficial in the management of these patients. So what do we prescribe for patients with acute rhinosinusitis? So if the patient has mild disease and has not received antibiotic therapy in the past 4 to 6 weeks, you can prescribe amoxiclav at 45 to 50 milligrams per kilogram, or cefuroxime if they're allergic to penicillin, or macrolide if they have cross-reactivity to the cephalosporins. For mild disease who have received antibiotics in the last 6 weeks, or moderate disease, we prescribe amoxiclav at 80 to 90 milligrams per kilogram, or you can go straight to cephalosporins, or you can use a quinolone. So over the past couple of months, we have been finding, well, anecdotally for me and some of my colleagues, that the patients have not been responding well to amoxiclav. We're not sure if there is a resistance because no studies have been done, but we have had to go straight to the cephalosporin or the quinolone, especially levofloxacin, for patients to get some relief. Moderate disease, again, high dose amoxiclav, or you can go to fluoroquinolone or a combination, usually with metronidazole or clindamycin to cover any anaerobes. The duration of treatment is very important. So one of the drugs that people love to use is azithromycin, because we think that patients will have compliance, because it's a one a day, quick to use, but it has not been found to be very effective in the management of moderate to severe acute bacterial rhinosinusitis or patients with otitis media. The treatment that is recommended for acute bacterial rhinosinusitis, especially if there are complications, is 10 to 14 days. And by day 10, there's 95% eradication. For patients that are admitted to hospital, we give high doses of IV amoxiclav, 80 to 100 milligrams per kilogram in 3 divided doses, along with anaerobic coverage, usually metronidazole or clindamycin, and meningitic doses of IV ceftriaxone, anywhere between 75 to 100 milligrams per kilogram. Surgical management is indicated if the patient has group 4 to 5, so orbital abscess, cavernous sinus thrombosis, and any intracranial complications. The empyemas are associated with the worst morbidity. There's a 30% morbidity associated with subdural empyemas, and therefore a high index of suspicion must be had for patients who present with neurological symptoms. So these patients may have residual hemiparesis, abnormal neural cognitive functioning, and they may have visual acuity disturbance as well. Subdural and epidural abscesses will also require neurosurgical intervention. So I just wanted to present some data that we saw at Bustamante Hospital. What we noticed was that we had, because of proper antibiotic prescription in terms of duration and appropriate dose and the correct agent, we were not seeing a lot of patients with complicated sinusitis. So in 2017, we saw 4 patients, 2 males, 2 females. In 2019, we saw 2 patients that were admitted to our ward. In 2021, during the COVID, we saw 2 patients, 2 male patients. And then this year, we just started to see like a lot of patients coming in. So we have had 7 patients so far with complicated sinusitis, 2 with intracranial complications, and the other 5 had moderate to severe orbital complications. So we had 3 orbital abscesses that required drainage. So the patients that presented fell within what is seen in the literature. So most of them were over 10 years, and we had 2 that were 10-month-old. 2 patients, those with intracranial complication, required neurosurgical intervention as well as ENT endoscopic. Well, sorry, open sinus surgery. We don't have endoscopic sinus surgery, but endoscopic would be ideal. And most of our patients responded well to high doses of IV antibiotic. Okay, so I wanted to discuss a case that presented to us to see how you would manage this patient and what you thought about the management of the patient. This patient presented to us with a history of no known chronic illnesses, a 9-year-old female. She had headaches, facial pain, nasal congestion, occasional rhinorrhea for 2 weeks, and a frontal swelling for 1 week. She was treated by her private practitioner for recurrent sinusitis in the past 2 years. On presentation, she was initially afebrile and generally well, and she had a 2 by 2 centimeter fluctuant frontal swelling, inferior turbinate hypertrophy, and her otoscopy was normal. And she had grade 1 tonsils and mucopus in the oropharynx. She was prescribed Avamis, Augmentin, and Loratadine, and the private practitioner performed serial aspirations of the frontal swelling, and pus was aspirated on each occasion. No swab was done for culture sensitivity. The antibiotics were switched after a week from Augmentin to Zinat, and the patient was finally referred to Bustamante Hospital after 3 weeks of initial presentation. So we're going to do a Zoom poll now on what is your initial diagnosis of this patient. And for my members in the room, anybody would like to suggest what the diagnosis could be?
So for persons online, what's your initial diagnosis? Subperiosteal abscess, chronic rhinosinusitis, sorry about that, chronic rhinosinusitis, orbital abscess, Potts puffy tumor and cavernous sinus thrombosis. Which one sounds like it?
Guys in the room, Dr. Chen, I have to keep calling on you.
Complication of the
Yes. Anybody else? Sandoz, please give Dr. Chen a prize. Yes, you have that advantage. We have the results of the poll.
30% says subperiosteal abscess. So that's the results.
All right, so it's less likely to be chronic rhinosinusitis. Remember, we said this is more associated with inflammation, and complicated sinusitis is more associated with acute bacterial rhinosinusitis. So subperiosteal abscess and Potts puffy tumor would be high on our differentials. She didn't have any ophthalmoplegia or eye signs, so cavernous sinus thrombosis is low for now. When she was admitted to Bustamante, she was noted to have tonic-clonic seizures and the preseptal cellulitis worsened. Because of the seizures, she was reviewed by neurosurgery team and a CT brain and sinuses was ordered and dilantin commenced. Her white blood cell at the time was 8.5 with 75% neutrophilia. These are the images of her CT scan. As you can see, she has thickening of the mucosa in the left maxillary sinus. This was also seen in the ethmoid, sphenoid, and her frontal sinus, which were still a bit rudimentary. And you can see there that there is a collection at the frontal sinus on the image on the left. All right, so our other Zoom poll. So based on this additional information, what would be your best management plan?
All right, so the options: IV antibiotics for 2 weeks, burr hole plus or minus craniotomy, endoscopic sinus surgery, frontoethmodectomy, I am good, and maxillectomy. So those are the options that we have. A hand is raised right here.
I would say the burr hole
Why, Doc?
for drainage of the collection. She seems to have neurological symptoms, which suggests that there is a collection there, which she'd have to evacuate or to drain.
Thank you. What's your name, Doc?
Rebecca Daly.
Where do you work?
I work at Chairs currently.
Okay, thank you. Sandoz, can you give Doc a prize?
Indeed, indeed.
Very good answer. So that's exactly what was done. Neurosurgeon performed burr hole and evacuation of the empyema. Patient was placed on IV rocaffin at meningitic doses, as well as IV amoxiclav and flagyl for a complete duration of 21 days. The dilantin was continued, and the patient was discharged 10 days post-surgery. She had a repeat CT scan, which showed resolution of the left pansinusitis and no intracranial collection. So even though she had left pansinusitis at the time, because of her instability with the seizures and her neurological symptoms, anesthesia thought it was prudent to just drain the empyema, and if needed, we would come back to address the sinuses. The sinuses responded well to IV antibiotic therapy, and she required no surgical intervention from that point of view. All right, so thank you for participating. So the key points to remember is that complicated sinusitis requires a high index of suspicion. The diagnosis is mainly clinical and timely intervention is key. So if you have a patient with orbital complications or a patient with persistent symptoms beyond 10 days, please refer the patient on for further management. Pediatric patients often have atypical presentations, so they should be referred once they're not responding to medication. Complicated sinusitis usually requires in-hospital management, so not repeated aspiration in your office. And IV antibiotic therapy is effective at appropriate doses for small subperiosteal abscesses and for preseptal and orbital cellulitis, as well as for the management of acute bacterial rhinosinusitis. And a multidisciplinary team approach is best for the best clinical outcome of the patient. And these are my references. Thank you.
Wonderful, wonderful. Thank you so much. All right, so we're about to have a quick Q&A. We're going to go back and forth like a nice little tennis match here, me and Nakia. So I think first for the room, Nakia, any
Yes.
questions from the room?
So the floor is open. So are there any questions coming from the floor before we take some from persons online as well? And we have a roaming mic. So you can direct your question directly to our first presenter, Dr. Marsha James. Yes, so I see a question. No, going once,
That means it was a perfect presentation.
going twice. Don't be shy.
All right, Doc, you're not off the hook. I have a few online here. All right. So the first question was from Professor Durrani. Any role of vectors in disease? That was the question.
Is it possible for him to clarify? I'm not sure if I understand the question properly.
Agreed. Prof, please, if you're still online with us, please just expound so we can ask. A 3-year-old child getting frequent cold and cough almost every 6 weeks, can it be linked to sinusitis?
All right, so again, that is the epidemiological age group for patients with complications from upper respiratory tract infections. But one of the things you have to consider is that there may be mechanical obstruction by the adenoids. So you should consider if this patient may have adenotonsillar hypertrophy or adenoidal hypertrophy, and this can cause rhinosinusitis.
Thank you so much. My son, age 12, is currently affected by this condition. He just completed a course of Augmentin 625, Ascaril 10 milliliter, and Arius. However, his symptoms persist and has been going on for 3 weeks now. He is congested, frontal headache, wet barking, cough sputum is now yellow. Please advise me on further care. Thank you.
I would advise her to take her son or his son to see an ENT specialist so the patient can be examined properly and the appropriate investigations and management instituted.
Okay, wonderful. One more question, or a few. For the BHC hospitalized patients, do you have data on their COVID-19 history, whether once or recurrent COVID-19 episodes?
So that would be something that we're looking into now. So for us to correlate the incidence of the acute sinusitis with their COVID-19 results, unfortunately, it depends on when we do the swabs on the patients, because we're getting the patients after they have already been treated by their general practitioners. So unless we do probably COVID-19 antibodies, we may not be sure that it's COVID-19 related, but that is something that we should definitely look into since we have seen this uptick in presentation.
All right, perfect. I think the question from Prof, the follow-up is if there's any vaccine available.
Oh, vaccines. Okay, so remember that we spoke about the 3 main bacteria that are associated with ENT infections. So the Hib and strep pneumonia, if our patients are immunized, the incidence is reduced. But for the others, there is no vaccine at the moment. And remember that most cases of acute rhinosinusitis are viral.
Perfect. Another one here. Excellent presentation. Does sinusitis cause dental cavities?
I've not read in the literature where sinusitis causes dental cavities, but there's an increased risk of dental infections, especially for patients with maxillary sinusitis, if the root of the tooth is within the sinus itself and the patient has recurrent acute sinusitis.
Wonderful, wonderful. And the very final one will come from the room. Where is my doctor?
The mic.
Right here.
Hi, good morning.
Good morning.
I am Dr. Wu from Alexandria Health Center, St. Anne. My question is, I'm not sure it's quite relevant with your topic, but for the allergic rhinosinusitis for chronic cases, I used to get Montelukast, especially the one the Sandoz have oxygrade is a good one to use. And then is that really reduce another recurrent episode? Because where I stay is the upstate, and with this heavy weather changes, patients have a lot of recurrence for rhinosinusitis. So I normally give oxygrade 10 milligrams for a month. After that, I find out the recurrent episode become more reducing in the future. Is there any literature or research saying that it can be given for Montelukast for a month for the allergic rhinosinusitis chronic recurrent cases?
Yes, and I think Sandoz has literature to that effect as well. So we do, especially for patients with atopy, allergic rhinosinusitis patients with asthma, we do give them Montelukast for up to 3 months. Consistent therapy, and this has been found to reduce their exacerbations of the allergic rhinitis as well as asthma and rhinosinusitis. Thank you. Thank you for your questions, and
One
thank
more
you for
question
listening.
before you
there
go,
is
right
another
over here. Hi there.
Okay.
I no problem. My name is Dr. Kim Rose Goodall, and you made mention that azithromycin, yes, most practitioners, I must say, especially because of low compliance, and most persons don't return, especially if they're feeling better. So you want to ensure you cover everything, yes. My concern with my patients, sinusitis or rhinosinusitis, I mean, if I were to put it on a rank, that's probably the second most common thing I see. Most times, as you rightly said, it is viral in origin. So my practice is I don't tend, to be honest, to prescribe antibiotics immediately. I do like to prescribe nasal sprays and such, and just to treat the symptoms first and then follow up, especially because the duration of treatment is 10 to 14 days. But I wanted to know if there's any literature that would indicate it is improper, or is it best to start on antibiotics? But also, the emergence of the whole antibiotic resistance. That's exactly why the augmentin is no longer working, and we have to use levoflox now. So I wanted to know, just from your experience and expertise, what do you recommend?
Literature actually recommends that you don't start antibiotic therapy right. Limitation that it is in Jamaica. Not to return, they tend not to be compliant. And so we often give them a prescription for antibiotics. Patients will say, don't take antibiotics that are persisting beyond 5 to 7 days. Or we ask the patient to return if it's possible. Patient is compliant and cooperative. Yes, so because we often only get one chance to see the patient, especially in the public health system, sometimes we do overprescribe antibiotics or inappropriately prescribe antibiotics or antibiotics for the entire duration. Their friends and relatives. They have a few over in the cabinet. So it's important for us to educate them as well on antibiotic use. Oh, I'm so sorry. All right, so sorry about that. So the literature does show, because that most cases are viral, that there is a period of observation that can be used in terms of antibiotic use. So you can say to your patient, if your symptoms are persisting 5 to 7 days, then you can start antibiotic therapy. Unfortunately, for a lot of us in the public health system, because you only get to see the patient once, and especially for us being a tertiary referral center, and we see a lot of patients from outside, with patients we tend to prescribe antibiotics. One of the problems as well is that the duration, patients are not very compliant, and this is where the antibiotic resistance comes in. So yes, there is a role for observation, especially in highly motivated patients and patients that you know that will return. The management would be non-antibiotic. So you treat the underlying symptoms. If there's allergic rhinitis, you manage that, and you give them symptomatic relief, decongestants, antihistamine, and their intranasal steroids, as well as Montelukast. That's okay. Well, right. So there's no hard evidence, but what some practitioners have been reporting, as well as for myself anecdotally, is that quite a few of our patients are not responding to the amoxiclav, even at the therapeutic dose. So we tend to, because we're seeing patients after they've already been treated by their GPs, we tend to go higher. So we go 80 to 90 milligrams. Of the amoxiclav, but even then patients have not been responding. So when we review in 5 days, we normally switch or we start them immediately on the cephalosporin. For adult patients, we have been using levofloxacin, which has been shown to give good effect. Azithromycin is just prescribed all the time for everything for some reason, because it's compliant, but often it's not helpful. And, I think we should really be better antibiotic stewards. So, educate the patient and say, they do always say, doc, I need some antibiotics, but, tell them not in this case, you don't need antibiotics.
Yeah, for very recurrent one for the children, I know everybody is using these days for cold-amoxiclav all the time, and I even worry it will be, one day we will have resistance for cold-amoxiclav in Jamaica. But my question is, just very young children, like about 8 or 9 men old with recurrent rhinosinusitis and infected, instead of amoxiclav, just good old amoxil, can we use that for the rhinosinusitis cases? Because what I worry is if I use that amoxil alone, it would not be that much effective, because everybody is just using cold-amoxiclav. It's like a trend in Jamaica now, I see these days. So your opinion, I wanted.
Yes, so for recurrent cases, I don't think amoxicillin, even at high doses alone, would be effective. Especially for your older patients with recurrent episodes. And remember as well that you need to see if there are any underlying causes. So a lot of these patients who present with recurrent upper respiratory tract infections and rhinosinusitis, they may have underlying anatomical abnormalities, including adenoidal hypertrophy as well. So, you should investigate these patients to see if there is adenotonsillar hypertrophy, as this is one of the common causes of obstruction.
Use combination therapy.
Definitely for recurrent cases and cases that are persisting despite high dose amoxiclav therapy, we will add metronidazole. For patients with orbital complications, intracranial complications, or symptoms persisting beyond 14 days, we do add metronidazole or clindamycin, something with broad spectrum anaerobic coverage. Any other questions? No, sir.
Good morning. Just a concern that in this patient, there was a series of seizures. And then both in the management and attention is not paid to that aspect. being a child and the consequences of seizures after some time.
Right, and so patients with neurological symptoms, they're at a higher risk of morbidity and long-term complications. So, when you have pediatric patients with persistent headache, frontal swelling, periorbital complications, don't try to manage that in your office for 3 weeks. Refer the patient for specialist intervention. Any other questions? All right, thank you so much.
Wow. So I'm sure everyone in attendance, both virtually and in the audience, would have really benefited from Dr. Marsha James' presentation. So thanks again, Dr. Marsha James. Excellent presentation. Okay, so we're just gonna show a quick video before we introduce our next speaker. So you could just watch online.
At Sandoz, we are proud of our long front line of scientific progress. For well over a century, we've been discovering, developing, and delivering medicines that have improved and extended the lives of millions of people around the world. A key division of Novartis, Sandoz is a global leader in generic and biosimilar medicines. With a growing portfolio of over 1,000 molecules, we're the largest generics company in Europe, the second largest globally, and aspire to be the world's leading and most valued generics company. But what really makes the difference at Sandoz is the people, who are united by a shared passion and purpose to pioneer access for patients. This powerful purpose inspires us to continually find innovative new ways to help patients around the world access high-quality, off-patent medicines, affordably and sustainably. Curious to learn ever more about themselves and the world around them, and unbossed in the way they achieve their goals, our associates deliver on our purpose in all they do. Equally importantly, they always strive to operate with integrity and transparency, and to the highest ethical standards. Every day, we work in partnership with doctors, nurses, and other stakeholders in the global healthcare sector to earn the trust of the communities and serve by ensuring our medicines reach patients.
Thank you so much. So we'll move right into our next presentation. And so with that, I'll invite our able medical representative, Christopher Beecher from Sandoz, to do the introduction of Dr. Keri-An Bridgewater.
Thank you, Nakia. Good morning, ladies and gentlemen. So today it is my pleasure to introduce to you our guest speaker, Dr. Bridgewater. Dr. Bridgewater hails from the island of Trinidad, her official place of birth, but she moved to Jamaica in her formative years, where she would have taken a keen interest in the sciences. It is with this passion that she pursued her medical degree at the University of the West Indies between 2006 to 2011, receiving honors in surgery and internal medicine with a distinction in obstetrics and gynecology. It was during this degree that Dr. Bridgewater discovered her love for women's healthcare, and she promptly proceeded to do her postgraduate studies in obstetrics and gynecology, which she completed with high commendations. Dr. Bridgewater believes strongly in providing women with the best healthcare possible, and as such, she has done further training in laparoscopic and cosmetic gynecology. Beyond her intelligence and academic prowess, Dr. Bridgewater is also an advocate for women's health. This led her to both be the vice chair and the then chair of the Junior Fellows of American College of Obstetrics and Gynecology, which she has presented at many symposiums locally and internationally regarding factors concerning women's health. Dr. Bridgewater works in both the public and private healthcare sector, and in her limited free time, she likes to travel and dance. Please help me welcome your esteemed colleague, Dr. Keri-An Bridgewater.
Thank you very much for that introduction, Mr. Beecher. And thank you, and good morning to everyone. With no further ado, I'd like to go into my presentation today, which will be on the effective management of cystitis in women's health in pregnancy and beyond. So first and foremost, I do need to make some disclosures. Before I can disclose, I would need to show you. One moment, please. We're having some technical difficulties. Hello? Where did I point to? So first, I have some disclosures to make. That first and foremost, this presentation is based on publicly available information, and that the opinions here are that of me, the exhibitor, and not necessarily of Novartis as a company. These are for educational purposes for those of us that are present, and not supposed to be for distribution outside of its desired intention. I'm going to just simply state that these are the beliefs, to the best of my knowledge at this point in time, based on accurate research to date, and that I have no conflict of interest in being here today and presenting on this particular topic. So just to get an idea of what the scope of the presentation is going to be, first, let's just go over what exactly are urinary tract infections. We're just going to talk a little bit about the definitions. We're also going to talk about why are we discussing this? What is the burden of the disease? What is the clinical relevance of this disease? Why we are talking about it today? And then, of course, we're going to talk a little bit about the approach to care, diagnosis, as well as treatment, and if there are any special considerations that need to be made for this particular subgroup of patients. So technically, my presentation is on urinary tract infections, and that spans between that of the lower urinary tract, of course, cystitis, and the upper urinary tract, talking about pyelonephritis. Now, cystitis is typically a symptomatic infection of the bladder, and I'm sure we're all very familiar with this. We know the presentation. These patients typically come in with a history of frequency of urination, so they're passing their urine more frequently. They have urgency where they have difficulty holding their urine. As soon as they have the urge, they have to utilize it and go find the nearest restroom as fast as possible. They typically present with a dysuria, which most patients will describe as cramping in the lower abdomen, either on realization that they have the need to urinate, or in some cases during the actual process of urination as well. These patients will sometimes also present with hematuria. They'll notice that they see blood on wiping or blood in the toilet after urination. And this is more typically associated with more severe cystitis, or depending on the type of bacteria that is present. Of course, pyelonephritis is when it has now ascended into the upper urinary tract system and has more fulminant picture and a more fulminant presentation. These patients will typically present with fever. They will complain about flank pain or loin pain. They can present with nausea and vomiting on the background of their other presentations from the lower urinary tract symptoms. So they will also have your frequency, dysuria, etc. But outside of this classic presentation and these typical urinary tract infection definitions, there's also a component that I would like to impress upon us, particularly today, especially in the subgroup of pregnant women, and that is of asymptomatic bacteriuria. So asymptomatic bacteria is exactly what it sounds like. So the patient has no symptoms. She's going about her day-to-day activity. She's not aware that she has been colonized by bacteria. But when you do a urine culture, you are noticing that you have bacterial growth of greater than 10 to the 5 or greater than 100,000 colony forming units per mil. Now, typically for this diagnosis to be made, you really should have 2 separate cultures growing the same bacteria. But this is a slight glitch because as we talk about this condition going forward, you will realize that this is not necessary in the pregnant women. So what's the incidence? The incidence of bacteria in pregnant women is actually just about the same as non-pregnant women. However, recurrent bacteria is more frequent in pregnant women, in addition to more ascending infections such as pyelonephritis. It's actually seen at a significantly higher number in pregnant women than the general population. Why is this? Now, For beginners, for starters, women are already predisposed to urinary tract infections. We have shorter urethras than our male counterparts, and therefore bacteria has a shorter distance to traverse before entering the bladder and starting to wreak havoc. However, in pregnant women, there's some other factors that put them at even higher risk of bacteria, as well as urinary tract infections. These include things like dilation of the urethra and the ureter, actually. And this is really because of the elevated levels of progesterone in pregnant women. Now, progesterone is created in high levels in pregnant women, and it's really supposed to target the uterus. The purpose of high progesterone in women is to allow the muscle of the uterus to relax and to stretch and accommodate the growing pregnancy. However, its effects are felt all throughout the woman's body. So it ultimately allows for all of her muscles, unfortunately, to relax, including that of the muscles surrounding her urethra and her ureter. So what you will find is that there will be dilation of the urethra, so the opening will become bigger. There will be relaxation of the bladder as well because of the muscles involved in the bladder. There will be decreased tone to the ureter that carries the urine from, the kidney to the bladder, as well as decreased peristalsis in the ureter of pregnant women as well. And this also causes dilation of the ureters and the renal pelvis. So the entire urinary system becomes lax and dilated in a pregnant woman in comparison to a non-pregnant woman. Additionally, the vesicoureteral junction that is meant to be somewhat of a seal to stop backflow of urine from the bladder into the ureter actually becomes malfunctional, and they have an element of vesicoureteral reflux as well. And additionally, there's compression of the ureters from external forces. So as the uterus starts to go into pregnancy, because it is dextrovertated to the right, it tends to sit a little bit on the right ureter, and it can cause compression. It also causes engorgement of the vessels in the suspensory ligament of the ovary, which cross in the ovarian fossa where the ureters are also traveling. And all of these things form to cause compression, which therefore causes backup of urine and further dilation of the upper urinary tract, such as the ureters and the kidneys. So what is the relevance of this? Well, think about it like you're a bacteria. You're accustomed to having to ninja fight your way up the urethra into the bladder. Then you have to force your way through the vesicoureteral junction. And then normally you have these waves of water coming to wash you out. Sorry, a little too excited there. To wash you out, right? But because of peristalsis and urine constantly being ejected from the kidney. And that's what you're accustomed to. But now in a pregnant woman, oh no, you have clear passage. You now have a wide open area, whereas you had a small area to go up before. You have stasis, so you have urine that's sitting there and getting stale. That's a perfect medium for you to grow and flourish. And instead of having waves of water coming down and fighting you coming down the ureter, you actually now have reflux, which is pushing you forward and telling you, go up, go get her, go get her. So bacteria is living at its finest when it comes to pregnant women and infecting their urinary tract their urinary tract system rather. Additionally, there's some other physiological things that we've been noticing in the studies. So we found that there's actually a higher risk of glycosuria in the urine of pregnant women. So they have a higher glucose content in their urine, and this actually helps as a medium for bacteria. So it again encourages bacteria to grow and flourish. And they've actually found that interleukin-6 levels are actually lowered in pregnant women, and that there has been a direct correlation between this and the growth of E. coli in women's urinary tract systems rather. So women are at higher risk, but we talked about it and we said asymptomatic bacteria don't have symptoms, right? We know that, UTIs have all these other plethora of symptoms that we know how to pick up on. But what is the clinical relevance? Well, this is just a synopsis of what I was talking about before, that it's an easier access, easier ascension. So what's the clinical relevance of this? Okay, so they get more UTIs. We'll diagnose some more. We'll write some more prescriptions for antibiotics. Sandoz makes a little, they help us, right? Sandoz is able to help us in this process. But it's actually a little bit more than that, right? So what they found is that asymptomatic bacteria, which may seem like the most benign of all of the conditions that I've mentioned here, has one of the most clinical relevance. They found that patients with asymptomatic bacteria tend to progress towards UTI and pyelonephritis throughout the course of the pregnancy. And you may be like, okay, doc, no big deal. We kind of figured that out because eventually the bacteria will get to the point where she will present. But more than that, they found that asymptomatic bacteria actually causes pregnancy adverse outcomes as well. And that if we are able to pick up on it before it becomes a UTI, we can reduce the risk of these things happening by 70 to 80%. They have found that untreated bacteria in asymptomatic patients actually led to an increased risk of preterm birth, low birth weight, and increased perinatal morbidity and mortality in a vast majority of studies. They've also found that pyelonephritis, once developed, is also at a causes a significant increase in risk of adverse pregnancy effects, not just preterm birth and low birth weight in terms of the fetal outcome, but there's also maternal complications, or mothers are at higher risk of maternal anemia, as well as sepsis and long-term sequelae because of the sepsis as well. Interestingly, the studies don't show much of an association with cystitis, but a lot of the authors theorize that because cystitis is the thing that's on our radar the most, we are able to pick up on it earlier and we treat it earlier, and that's the reason why they're not seeing such a significant correlation with it. So what do we do about this? We found that asymptomatic bacteria has this adverse effect, but it's just that, asymptomatic. How do we know who needs treatment and who doesn't? Because this one's not going to come to us with symptoms. And the only way to know that is to screen. So the current recommendation from the American College of Obstetricians and Gynecologists, as well as the US Preventative Service Task Force, is that we are actually supposed to screen every single pregnant woman for asymptomatic bacteria. Now, I don't mean to put anybody on the spot, but if what's in the room here, how many people screen every pregnant woman for a UTI or for asymptomatic bacteria? Pardon? Have I let go of your shirt? Just a gentle tug, just a gentle tug. But this is not widely known. Generally amongst family physicians or even amongst my own colleagues as obstetrician and gynecologists. No, it does not count for that. So screening is with an MSU, a midstream urine. I know if I had changed the question, our stats would change significantly, right? But no, a MSU, actually a midstream urine is what is currently recommended as screening protocol for women in pregnancy. And they advocate for it to be done typically within the first trimester. So when next you see a pregnant woman booking and you're ticking up your form, we all write up the form for the antenatal screen, we check for the CBC, sickle cell, etc. Tick MSU. You'll be surprised what you find. And you'd be surprised what you might be guarding against in that woman's care. All right. So how do we screen? With a midstream urine. I mean, you could also do a catheter specimen urine, but I really don't recommend that. And I figure for obvious reasons, we all understand why. So yes, a simple midstream urine is all that is needed. And I know a lot of us, we have this thought process about, pre-cleaning and wiping the labia with an antiseptic. And I found very interesting in my research that this is actually no longer advocated for. They've actually done tons of studies comparing midstream urine samples that were taken from patients who had pre-cleaning of the vulva and labia prior to their urine sample being taken and not, and they found that the level of contamination was actually pretty much the same. The most important part about an MSU is that you collect the middle part of the urine. So the clean catch, which is the second part. So you allow her to start passing her urine and just to catch the middle part. And that therefore decreases the chance of skin contaminants coming into your sample. Okay. So the current recommendation is that everybody should be screened with an MSU, but there are persons who are for further consideration. So persons with sickle cell disease, actually, according to the guidelines, should be screened with an MSU at every trimester, minimally. So at least 3 MSUs should be done for patients with that, because asymptomatic bacteria can be so deleterious in their case, especially if they do go on to progress to actual urinary tract infections. Persons with diabetes should also be screened more frequently. Of course, if a patient has a history of recurrent UTI, then you want to probably screen them more often, and any renal pathologies that put them at increased risk. When it comes to the other subclassifications, there are no obvious and distinct guidelines for how frequently they should be screened, but it was documented in multiple studies that they should have a closer or higher vigilance in these subgroups. Of course, you also need to have a low index of suspicion because, as I said, pregnant women just naturally are just, prone to this particular condition. So Dr. Wu, as you mentioned, we need to make sure to do our urinalysis at every visit. looking for not just the obvious, like the nitrite positive, you know, and your leukocytes 3+, but also looking for other subclinical things. So looking also for like proteinuria sometimes. Sometimes I find proteinuria can be an early sign of a UTI. And sometimes it's not necessarily a UTI, it could be a vaginitis or vaginosis. But whenever you see that in a patient's urine, think not just preeclampsia, but think infections as well, all right? And then also about worsening symptoms, because pregnant women naturally are going to have some amount of frequency because of the compression of the bladder from the uterus, right? But ask her specifically, have you noticed this getting worse? Have you noticed that you are able to hold your urine for a shorter period of time? Establish what her new baseline in pregnancy is, and to be vigilant for anything that seems like it's going to the left of that or progressing. So the good news is, even though women are at risk of UTI and pregnant women are that much more, it's the same bacteria as before, fortunately. The most common cause of UTI and the most common etiology or pathology or pathogen noted in UTIs in pregnancy is good, old, faithful E. coli. All right. So E. coli actually accounts for approximately 70 to 80% of our cases of urinary tract infections in pregnancy. As we know, this is typically from our fecal flora that simply migrates upwards. And of course, this is another reason why it is very important for us to counsel our women in general. This is just me advocating as a gynae, to counsel our women in general, and especially our pregnant women, about their safe health practices. Encourage them to remember to, you know, always wipe from front to back, because sometimes the patient themselves are inoculating themselves with this bacteria. Encourage them, you know, about general hygiene practices as well. Encourage them about making sure to avoid their urine after sexual encounters, because that is also known to be one of the predisposing risk factors for urinary tract infections from colonization, etc. Right? The other pathogens that are typically found include things like Klebsiella pneumoniae, Proteus, Enterobacter, Staphylococcus, pretty much the same profile that a non-pregnant or the general population is at risk for. So how do we treat this? So in an asymptomatic bacteria, of course, you would have gotten your culture result. So the benefit of this is that you already can start with culture-directed antibiotics in this case, all right? In terms of your patients that present with cystitis in pregnancy, because of the fact that this can accelerate or progress, you would want to start empiric treatment for this patient in the meanwhile, because the general turnaround from midstream urine is gonna be about 48 hours. You can sometimes call in on, 24 hours and get like, a preliminary, but you're not typically gonna get a full result until that time. And in that time, that patient could have progressed from a cystitis to a pyelonephritis or whatever the case may be. And so we typically want you to send off the sample for MSU. You want to start empiric treatment. Remember to always send off the sample before starting it, because if done in the other direction, it can affect your outcome or your yield as well, okay? Now, once you're able to get the culture results, then you want to start them on culture-directed antibiotics, and typically oral medication is sufficient for cystitis in pregnancy. So, you want to just complete a 7-day course, and the current recommendation is there's no guideline or suggestion that there's a need for post-culture for simple cystitis in pregnancy, provided it's not complicated or anything more aggressive. For your pyelonephritis, again, you want to start with empiric treatment. So you want to take off that MSU as quickly as possible, but because this is a more severe infection, because this is a more aggressive infection, not only do you want to start empiric treatment, but you want to start with parenteral treatment for these patients. You want to start with IV, preferably, IM in some considerations, depending on the scope of your practice, your patient's access to care, etc. You want to be starting them on parenteral antibiotics for starters. And you really want to complete about 48 hours worth of parenteral antibiotics for this patient. You want to, by that time, you should have your culture on hand, so you know that you can do now culture-directed treatment. Hopefully, what you started them on is within the scope of your culture-directed, and you can just continue them on that regime. And ideally within that 48 hours, my apologies, the patient should also be showing signs of clinical improvement. Because remember, pyelo tends to once the patient's body read the textbook, show with fever and nausea and vomiting and things of that nature. So provided that by that time, within the 48 hours that those symptoms have been resolved, the patient should ideally be afebrile at this point in time, then you can switch to your oral agents at that point. And you want to complete at least a 10-day course for patients with pyelonephritis in pregnancy. There is no 100% guideline on this. I've seen conflicting information. However, majority of studies and majority of bodies currently recommend that you do a post-treatment MSU for pyelonephritis, just to ensure that you've gotten clearance for pyelonephritis in pregnancy, right? And some advocate for prophylaxis with the form of nitrofurantoin going forward. So we spoke about, we've spoken about the treatment, and I keep using statements like, start antibiotics and empiric and, culture directed, but it's pregnancy. What can you use in pregnancy? So typically, the most frequently used antibiotics in pregnancy are that of your penicillins, with or without your beta-lactamase inhibitor, and your cephalosporins. And the reason for this is because these are safe in all trimesters, right? And of course, Sandoz has us covered with our Keri-An, right? And our Zinat as necessary at a reasonably affordable price, right, guys? Thank you. Now, unfortunately, as was alluded to earlier in the first presentation, and I believe there is a presentation later on talking about that specifically, there have been some forms of antibiotic resistance, and our utilization of antibiotics sometimes gets thwarted. So sometimes you're like, yes, it's a cystitis, I'm starting them on there. Keri-An, I'm starting, she has a query penicillin allergy, so I'm going with my Zinat instead, and I'm giving that to the patient, and you get back the culture results and you see a big R. And I said, well, what to do now? Well, there are other antibiotics that can be used, but you have to be vigilant about when you're using them. So I mentioned earlier about, prophylaxis nitrofurantoin. A lot of physicians, especially my own colleagues, lots of times we're like, is nitrofurantoin even safe? I don't see this often, but nitrofurantoin actually tends to be a very good option, especially in some cases where there are extended spectrum beta-lactamase resistance. Nitrofurantoin can actually be utilized in those patients. It is a little tedious in that it, unlike your Keri-An, which is Q12, and your cephalosporins, etc., it is actually a Q6 hourly drug, which sometimes causes a little bit of an issue for you in terms of patient compliance. But when you put forward to them that there are other options, are IV meds and admission, you'll be surprised how soon you get them to comply. So just always remember that nitrofurantoin is available. Nitrofurantoin is typically recommended in the 2nd and 3rd trimester. There is a bit of debate about it in the 1st trimester. ACOG and a lot of the other guidelines recommend that you can use it in the 1st trimester if you find that the benefits outweigh the risks. But I would say that this chart is generally your safest bet. If possible, avoid in the 1st and stick to it in the 2nd and 3rd. Of course, there's also good old Bactrim, or trimethoprim sulfmethazole, right? Which a lot of times we just think off the bat, it's a no-go in pregnancy, but the truth of the matter is it can be used in the 2nd trimester without any adverse effects. So you just have to be very judicious about when you use it and how you use it. And they're the ones that we just generally say, please, 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 pretty please stay away from as best as possible. And those include your aminoglycosides and your fluoroquinolones in pregnancy. So no levoflox from Sandoz, please, unless it is unavoidable. Now we can sometimes use it, and I know it has become a bit more topical because with all the antibiotic resistance, we're starting to use it a lot more for upper respiratory tract infections and other things along those lines. But typically for the 3rd trimester, we ask you to, as best as possible, stay away, because there have been documented evidence of ototoxicity and things like that with the use of some of these antibiotics in pregnancy. Now, other areas for special consideration: Strep B, Group B Streptococcus UTI in pregnancy. Now, you treat as before, as mentioned before, you want to start your empiric. Once you find out that's what it is, you want to give culture-directed antibiotics, but you also need to remember this when you're transferring this patient. So if you're going to transfer this patient to the hospital for delivery, or if you're transferring to another OB for continued care, you want to make a note of the fact that she had this UTI in pregnancy, because it's very important for us in the intrapartum period as well. We always make sure to give ampicillin or some kind of on a penicillin derivative in patients with this once the membranes have been ruptured, because it does put the neonates at an increased risk of neonatal infections. Right? And if patients have recurrent UTIs, of course, you notice that this patient has 3 or more UTIs in the pregnancy while under your care, you need to look for compounding factors. So check for, do your KUB, look for renal calculi. There's something else that's putting this patient at risk. Check for abnormalities in the renal system, like the diverticuli. You want to check to see them, make sure they're not immunocompromised. And in those patients, you definitely want to consider prophylaxis going forward with the use of nitrofurantoin. And of course, the presentation said and beyond. So in the postpartum course, you also need to maintain this level of vigilance in patients, because a lot of the things that we spoke about with the progesterone changes will persist for up to the first 6, and some evidence is actually showing up to 12 weeks postpartum that they can have some of these subsequent secondary effects. And so we need to remain vigilant at this time to guard our patients against unnecessary infection and sequelae. So in summary, colonization and infections of the urinary system is very common in women, and even more so in pregnant women. Even asymptomatic infections can lead to seriously adverse neonatal and maternal effects in pregnancy. And so we need for universal screening amongst us as physicians, and to remain vigilant for our women throughout this time. When we do treatment, we should start as necessary, but make sure as best as possible that it is culture directed and appropriate for the severity of the infection. Thank you. These are my references. And thank you for your time.
Thank you so much, Doc. All right, Nakia. So let's take from the room first. We have some questions online, but we're gonna go from the room first. Anybody here have any questions for Dr. Bridgewater?
Yes, so we'll ask persons here. Sure, go ahead.
Hi, good morning. I'm Dr. Clark from Oxford Medical Center. All right, question. You said that we should screen the pregnant woman for UTI. Is it that we screen each trimester or one time?
Yeah, so for the excellent question. For the low risk patients, just screening at onset. So in the first trimester is sufficient. Okay. So ideally at the same time that you're requesting the antenatal screen, just put MSU as well.
But suppose they get back the UTI, but they're asymptomatic. How do we then, address? Well, I guess if they're asymptomatic, we won't know.
Pardon?
What's the likelihood of recurrence then of this asymptomatic bacteriuria if you first treated it in the first trimester?
So what they've actually found is that if treated, the risk of it comes down to about 70 to 8. It's reduced by 70 to 80% of it happening or, developing into anything further on in the pregnancy. Thereafter, the recommendation is just to do your routine surveillance. So continuing with your urinalysis, continuing with your, your history taking during your examination period with the patient, ensuring that they're not developing new symptoms, etc. It's similar to the fact that, we screen the hemoglobin at the beginning, and yes, you can develop anemia going forward. And yes, there is recommendation for repeating it later on at 28 weeks, but between then and then, we're not entirely sure. So all screening protocols always have to benefit the risk-benefit ratio and the cost-benefit ratio as well. And so the current guideline is just on the presentation in the first trimester, screening at that time, and then anything thereafter is based on symptomatic treatments or any risks that are identifiable risk factors for a low-risk patient.
All right, anybody else in the room? All right, let's see if this one sparks the conversation. From Dr. Vanessa Green. Is the glucosuria noted throughout all 3 trimesters, or is there an increased incidence in the second trimester?
So when I read, I did not actually see a specific to which trimester it was most predominantly noted in. However, based on the natural physiological changes in pregnancy, I would suspect probably the second trimester might be the most prevalent, simply because of the increase that you're going to undergo generally with your plasma volume and your GFR, and your increase in terms of your vasodilation. I think somewhere around that time period would be the most likely time. But that's an extrapolation based on my knowledge of how the body progresses in pregnancy.
All right, thank you. And Professor Durrani asks, does diet play a role in UTI?
So dietary factors, did not come up in the reading that I was doing in preparation. However, the truth of the matter is increased, one of the things that we have a problem with in general with urine and UTIs is stasis is a predominating factor, especially in a pregnant woman. And of course, concentration of the urine, which is why the glycosuria comes into play. So the fact that glycosuria has been identified as a risk factor associated with the incidence of urinary tract infections, then conversely, I think we can extrapolate that's an increase in your dietary carbohydrates that would increase your, your concentration of this, and therefore your risk for glycosuria would have extrapolated risk associated with it. Of course, also water intake. I mean, we all know water is great from all areas and for all aspects of your life. And of course, increasing your water intake will therefore cause to dilute your urine, decrease the chance of glycosuria, and therefore we can extrapolate that should therefore be able to reduce your chance of urinary tract infections. And of course, the evidence has already been there to show that the use of certain foods can decrease your UTI risk, which is known from the general population. I believe we can extrapolate that to pregnant women as well. So like the use of cranberry juices, cranberries, tablets, things of that nature have been shown to decrease the risk of UTI. So I think from that information, that wealth of information that we already have, we can extrapolate that, yes, dietary factors would play a role.
Thank you very much. I just want to say thanks to everybody online. We have like 5,000 questions. Tamara McKenzie.
Enough time for same.
We won't have the time. But so Dr. Bridgewater, what's the dosage of nitrofurantoin?
So nitrofurantoin is normally 500 mil. Oh, I lied. Hold on. Yeah, it's 100. No, it's pause. No joke. No man, it's Q6 hourly, and it is normally given. It's a weird dose. It's like 100 milligrams. Yeah, it's 100 milligrams. Sorry, my apologies. I definitely started off with Zinat because I write that the most. But yeah, 100 milligrams Q6 hourly. So, and it's normally given for a period of 7 days. My apologies. Cytoxin.
Thank you very much. So I think this will be the last question. Can we change the pH of urine in treatment for early recovery? That's the last question.
So pH of urine is really a secondary factor from what goes in, what comes out type situation. I really do not have any knowledge base about how to change the pH of your urine via antibiotics or via dietary changes. And I did not come across that at the time when I was preparing for the presentation.
No, it's just that we want persons online. Sorry. I thought it was gonna spark conversation. Hold on. I did a 5K once when I was like 2.
Hi. This was I was really informed, excellent presentation.
Thank you.
I'm glad the question was asked about the dosage because I wanted to confirm if it was 100 milligrams or not. But in terms of the pH, so I won't speak about pregnant women today. However, for my patients, because it's usually sinusitis second, UTI first. So I'm really happy we're discussing this. But I find that when I see my recurrent patients, of course, we give them the Keri-An. And then if they're recurring, in terms of the pH, that's actually one of the most common things I recommend to patients with vitamin C. Because you find like with the cranberry juice, there's sugars in there, and the pineapple juices and such, there's usually some high level of sugar. So the vitamin C tablets, one thing that I usually recommend that I found really working a lot of persons. I mean, the patients aren't coming back unless they want to talk to me, which they do come back to do that. But the vitamin C dissolvable tablets, drinking that and then drinking water afterwards would increase the pH just enough to break down the bacterial wall to decrease the risk of recurrent infection. It's very minimal. It's dietary, but I find that this is working.
Well, thank you so much for that, because I hadn't seen it, but I'm definitely empowered with that information as well now. So thank you very much.
All right, any other questions in the room? I have 1 5K left in me. No? All right, thank you guys. right, and so for our major sponsors, we have a video that we're going to be sharing. So please enjoy this video
Yes,
from
so-
Sandoz.
So we'll just run a quick video, just to kind of give persons a pause before we switch into our next presenter. So ready up yourself, persons that will be doing the introduction. So we'll just take a quick 1-minute break. Thank you. And again, welcome, welcome, welcome back. And I'm sure persons at home are relaxing, enjoying the presentations at the moment, but I definitely want to make a special mention or shout out to the president of AGPJ, Dr. Donald Gordon. Welcome, sir, and your able executive body who are actually watching us online at this present time. So we're doing very well where time is concerned. And the presentation, as I said, when you're having fun, you don't even realize the time. So I will now invite our medical representative from Sandoz, Ms. to come and introduce our third speaker. So make her feel welcome. Jan?
Thank you very much, Nakia. Good morning, ladies and gentlemen. I am so pleased to be with you this morning and to have the chance to introduce our speaker, Dr. Keri-An Pate-Robinson, an alumna of Campion College, Harrison College, and the University of the West Indies. Dr. Pate-Robinson comes to us with a great depth of experience and knowledge in her field. She has spent close to 20 years serving in diverse roles, ranging from general practitioner and wellness clinic coordinator for the Manchester Health Department to chairs consultant at the University Hospital of the West Indies and associate lecturer at the University of the West Indies, Jamaica. Dr. Pate-Robinson is a scholar in the true sense of the word. Learning is one of her favorite hobbies, and it definitely shows in her rather heavy 13-page curriculum vitae. Having achieved her MBBS from UA in 2003, she proceeded to take the lifestyle-related disease prevention course at the Aichi Health Plaza in Japan, becoming qualified as a wellness specialist in 2007. In 2013, she completed her doctorate in medicine, in internal medicine, then went on to fulfill a fellowship in infectious diseases in 2017. As a lifelong academic, Dr. Pate-Robinson has completed 3 investigations, currently has 2 research projects underway and 1 planned. And given our background, we at Sandoz are particularly interested in your current study on antibiotic prescribing practices and effect of antibiotic stewardship intervention pilot program. She keeps abreast not only a yard, but also abroad by maintaining memberships in several learned societies, such as the International AIDS Society, the HIV Medicine Association, the American College of Physicians, and the Infectious Disease Society of America. In addition to being a true scholar, Dr. Pate-Robinson also unselfishly disseminates the education she gains. Her vast knowledge base and wide range of world-class experience, as well as having educational training responsibilities since 2004, has made her adept in delivering workshops and seminar presentations, and she has indeed been a staple at CMEs since 2013. One would think that all these accolades would absorb all Dr. Pate-Robinson's time. However, she has managed to be a singer, dancer, actress, triple threat, debuting her acting skills in her 3rd-year medical play entitled Smoker. Maybe Dr. Pate-Robinson can speak to what her next big role will be. Swimming, church activities, and being an avid student of Shotokan karate round out the list of extracurricular activities for this extremely accomplished wife and mom of 2. In other words, you are putting yourself in clear and present danger if you decide to mess with her. Without further ado, please join me in welcoming our speaker this morning as she presents on the topic, recommended antibiotic choices in community-acquired pneumonia. The ever elegant and eloquent Dr. Keri-An Pate-Robinson.
I don't think she's really talking about me. Good morning. Are we still in morning? Good morning, everyone. Welcome, ladies and gentlemen, those online. I'm so happy to be here with you today. And I hope I don't destroy too many of your brain cells, but let's get going. There we go. All right. Oh, I think we skipped one. So for the sake of transparency, as an exhibitor, this presentation is based on public available information, okay? Including information related to many products. The opinions issued are mine with help from many online sources and many experts. The slides have a primarily educational purpose. The contents reflect the best knowledge at this time that I can gather for you, and I hope that it helps. And I don't have any conflict of interest that I'm aware of. And I am, and this is, and I am paid speaker fees for this presentation by Novartis. All right, so let's get going. So these are our primary objectives. Sorry. We want to talk about mortality. Why is community-acquired pneumonia important? What are the risk factors for it that have been determined by many international studies? And what are the commonly implicated organisms, which many of you probably know about for many years, having been in private practice or public practice for some time. And we want to look at what's the current evidence-based approach to antimicrobial practices in community-acquired pneumonia. And, as mentioned by some of our previous speakers, good antimicrobial stewardship in this area is going to be critical because there aren't many new antibiotics coming out. Globally, that is reducing and the germs are getting a little stronger. So when we talk about community-acquired pneumonia, we're talking about usually an acute infection. So it's usually something short-term, and the patient has often acquired the infection in the community. So community germs, which can be drug resistant or drug susceptible, depending on the antimicrobial prescribing practices in the community. And this is an up-to-date definition. If you look at New England Journal of Medicine from 2014, Marsha defined it slightly differently, in that it's in persons who have not been hospitalized recently and have not had regular exposure to the healthcare system. Again, just trying to say this is something acquired in the community with germs that are hopefully less drug experienced and more susceptible to antibiotics. So when we look at some of the global statistics recently, and despite COVID-19 taking up a lot of the world's attention, there has been a fairly decent spread of data collected on community-acquired pneumonia, and some of that also because community-acquired pneumonia can be a secondary bacterial infection in those who have COVID-19. So there's been a lot of focus and attention on the respiratory tract. And we know that community-acquired pneumonia is common. Since the 1800s, it's something that's been looked at very carefully, and there's been a lot of research that has advanced our antimicrobial spectrum since that time. It's always considered potentially serious or life-threatening, no matter how simply it may start and how robust the immune system of the patient may seem to be, because there often is a poor recognition of immunocompromising factors in the average person. We don't think about the small things that make us more vulnerable. It's associated with considerable morbidity and mortality, especially in those who are older than 65. And part of that also has to do with the fact that there's a delay in recognizing that pneumonia is part of what is making them ill at the time. So then there will be delays in therapy, and because they're more vulnerable, they're less likely to survive. When you look at some of the European data, so those statistics that I was talking about were primarily from 2019 and more broad-based global data. There has been some recent or more recent data from various countries in Europe. A number of broad-based reviews were done, and the incidence of community-acquired pneumonia was thought to be anywhere between a little over 1 to almost 2 per 1,000 population. And it increased with age. And severe community-acquired pneumonia as an entity is something that has been looked at more commonly over the last few years, distinguishing severe from the average community-acquired pneumonia. And that is particularly because the mortality for severe community-acquired pneumonia can be up to 60%. So in 2019, if you look at this somewhat busy slide, I'm sorry, some of the ones with diagrams are going to be a bit busy today. So the top 10 causes of death in 2019 accounted for over 50% of deaths worldwide. And if you look at the decade between 2000 and 2019, lower respiratory tract infections were anywhere between the 4th leading cause of death and the 6th leading cause of death. And in terms of the 6th leading cause of death, that would be perhaps in the more developed countries. So it has been in the top 5 for a long time. Now, there are a number of other things that we tend to look at. Chronic non-communicable diseases are one of the things that we all think, okay, well, we've moved away from the days when infections took out most of us, and now we're into lifestyle-related diseases, chronic non-communicable diseases. That's what's killing the average person these days, and people are living longer. But infections haven't gone away, and pneumonia is one of them. So when we look at risk factors for community-acquired pneumonia, there are quite a few. In the past, we didn't have good data for them, but there have been a number of studies recently that have really helped to show us what we should be thinking about when we're evaluating our patients. And when you look at this slide, you can see that chronic respiratory diseases like chronic obstructive pulmonary disease and asthma are really up there in terms of the risk factors. So structural lung diseases, especially chronic lung diseases of whatever type, and that may also include things like cystic fibrosis and bronchiectasis in particular. Those diseases increase the risk of community-acquired pneumonia significantly, which from a physiologic perspective, I think we can all expect that that makes sense. You also have to think about other things, so because diabetes can be a significant risk factor, up to 33%, cerebrovascular disease and stroke, in terms of being a vascular equivalent, looking at inflammation, looking at circulation, and those who are vulnerable. A lot of these risk factors are things we know about, but don't necessarily think about specifically related to respiratory infection. Now, when we look at, so those are the non-communicable disease risk factors, but you also have lifestyle risk factors. And that's something that the whole world is focusing on a lot more now. How do we become healthy? How do we stay healthy? And lifestyle is a big part of that. Smoking, which I think most of us would understand being inflammatory, being toxin mediated, being something that causes physical, chemical, and other types of damage to the body. Smoking is one of the biggest risk factors, and smoking particularly affects the lungs, even from a structural perspective. And there are many studies that have evaluated that and found an increased risk for smoking and community-acquired pneumonia. And of course, the recommendation is always going to be stop smoking. It's not as easy as it sounds, but that is what we're going to say. If you really want to avoid that level of risk, and it's not just for community-acquired pneumonia, it's for any other illness, because it also affects atherosclerosis, it affects inflammation, it affects immune function on a very broad-based level. Alcohol consumption is still considered associated as a lifestyle risk factor for community-acquired pneumonia. Undernutrition is also noted to be significantly associated with risk factors for pneumonia. Contact with children, which I think many of us would understand. Children are incubators as much as we love them, and they grow germs and they share them. And we love them so much, we're going to come and get them. And then, of course, dental hygiene, which I think was mentioned earlier. So these are things that, with a small adjustment in how we manage our lifestyle, and sometimes a large adjustment, we can reduce the risk factors, not just for ourselves, but our family members or patients. So there are other risk factors that don't fall into those two categories that are quite notable. We mentioned age already. You can't get away from it. All of us are getting older, and our bodies are developing more damages, and they need more support. So age is always in there. We found, though, that in some of the studies, community-acquired pneumonia was higher in men than in women. And the specific reasons for that haven't been fully elucidated. And it's, of course, if you have structural lung disease or chronic respiratory diseases, as mentioned. And then funnily enough, I'm sorry, the little thing at the bottom covers it, but anyone who has co-infection with HIV is also noted to be more at risk for community-acquired pneumonia, and that's irrespective of the status of the HIV infection. So it doesn't have to be someone with AIDS, okay? So we're going to talk a little bit about pneumonia severity scoring systems, because from a clinical perspective, and I think most of you would be familiar with at least one of these, then we want to determine who is the more severely ill patient who will require admission to hospital, may need more intensive investigation or support, may not be somebody we should manage at home. The PSI, or the pneumonia severity index, is a little bit more challenging to utilize as an outpatient because it does require that you use an arterial blood gas measurement, etc. But the CRB-65, which I think many doctors are very familiar with, is a very useful tool on an outpatient or even in the emergency room basis to help you determine, okay, is this someone that I should admit or refer for further evaluation and support? And we use these things to also help with determining appropriate antimicrobial therapy, because the severity of illness, the need for inpatient care or ICU care also changes how you look at the germs that you might be dealing with. And, the CRB-65 is a little easier to remember because it's only 5 things. So in terms of general principles of management, and there are many, we can't go through everything today, but early identification is critical. And as I mentioned before, in the elderly, you have to be you have to have a lower threshold. You need to think about it earlier, even when the symptoms are not so robust, because sometimes general ill feelings, reduced exercise tolerance or activity or interaction may be your presenting symptoms for somebody who is over 65, especially if they already have other comorbid conditions, if they have dementia, if they have other features that put them at a significantly increased risk of being less able to communicate or mounting perhaps a less robust inflammatory response, which age alone is a contributing risk factor for. So generally speaking, there's a lot of back and forth about whether you should do diagnostic tests and whether you should do sputum cultures for every patient with community-acquired pneumonia. And maybe as an infectious disease specialist, I'd want that, but that's not practical in everyday life. So the recommendation generally is if you have somebody who's more severely ill or they require inpatient therapy, then yes, you should try to get a sputum culture. That may or may not help you because sometimes in between 25 and 75% of people, the sputum culture may come back negative, and some more recent data say about 40% of sputum cultures are going to be unhelpful. And there are many reasons for that. But once you're considering admission or the patient is severe, a culture is helpful because targeted therapy is going to be life-saving. And then, the hospital antibiograms, I'm sorry to mention it because I know we often don't have it, but many of our hospitals are working on creating it, and hopefully we will have that. And that's basically a guideline to use to say, okay, in our institution or in this particular community, the frequency of community-acquired pneumonia or, respiratory specimens giving you strep pneumonias, maybe about 75%, and 90% of them are susceptible to cefuroxime, but only 50% of them are susceptible to amoxicillin clavulanic acid. And so empiric therapy is much more likely to be effective if you use cefuroxime as opposed to amoxicillin clavulanate. We're getting there. We have had that in the past from some of our institutions, but it's not being maintained on a consistent basis, but we're hoping to improve that. Okay, and the supportive care is, antipyretics, analgesics, hydration, if in hospital, may include something more stringent like oxygen therapy, physiotherapy, etc. And sometimes outpatient physiotherapy is very helpful, especially for the more vulnerable or those older than 65. So when we talk about empiric treatment, don't worry, we're not spending long on this very busy slide, but we really, generally speaking, have looked at things from the perspective of, okay, if you're previously healthy, you don't have a lot of antibiotic exposures, so you're less likely to have a resistant organism, then it may be helpful to use a macrolide. And that was previously what was recommended. There's some disagreement between European guidelines and American guidelines, but the use of macrolide therapy alone was at one time advocated. We don't really advocate that anymore because rates of macrolide resistance have been increasing, especially among germs like strep pneumoniae, which is more often not going to be susceptible to a macrolide. And so we have to change things. And that's why we often now recommend a beta-lactam in addition to something for your atypical coverage, which the macrolide or the doxycycline would have been for. So from an outpatient versus inpatient perspective, it changes your thought process on what germs you may be dealing with. And it also changes your thought process because those germs that you're dealing with may be related to the host factors that led to them being susceptible and needing either a lesser degree of support or more. So when we talk about the common garden typical bacterial pneumonia that you might get, then amoxicillin clavulanate is still fairly good as an option, depending on that patient's drug exposures in the past and their unique risk factors. And we usually still recommend addition of atypical coverage for organisms such as Haemophilus influenzae, Mycoplasma pneumoniae, Legionella, etc., may also require addition of other antimicrobial agents. And if you're talking about influenza, which some recent international data is suggesting is still up there, although in Jamaica, we don't often test for it in the context of COVID-19, then that is something we may have to consider. It's still a significant cause of pneumonia. Whereas if you're looking at inpatient therapy, then you're going to use more often than not something intravenous. So ceftriaxone, because of its good pharmacodynamic and pharmacokinetic properties, is often one of the first choices because it can be given once a day, as opposed to something like cefuroxime, which has reasonable spectrum of coverage, can be given orally, so useful for the outpatient, and can be given as an inpatient, although the dosing would be 2 to 3 times a day. So it really depends on the patient you have in front of you and their risk factors. Now, we don't have as much in terms of molecular and diagnostic capabilities here. So we're not going to get the full respiratory PCR panel or some of these more molecular diagnostic techniques that you might find in a first world country. But those are changing our ability internationally to recognize what are the common causes of community-acquired pneumonia. Because before, if you were getting 20 to 25% of your cultures being positive, that means that at least 75% of your infections, you have no idea what the etiology is. And internationally, that's changing. So we're starting to understand a lot more about how community-acquired pneumonia works. So let's talk about the microbiology a little bit more. So just a reminder, because this is kind of the basis for your antimicrobial therapy, gram-positive versus gram-negative. Your gram-positives have a thick peptidoglycan outer coat or cell wall, that's the purple beads, whereas your gram-negative organisms have a very thin peptidoglycan layer in between 2 cell membranes. And so their susceptibility to different antibiotics is going to be different. And there are some drugs that will only affect a gram-positive organism, such as vancomycin, which is not commonly used, in the outpatient setting in particular, or say, aminoglycosides, which may affect both, but may be more needed for a gram-negative infection, especially for a hospital-acquired organism, which we're not really here to cover. So when you look at the microbial spectrum, we tend to separate it into outpatient, inpatient, and ICU care in terms of severity of illness versus the location of the patient's care, because that's helping us to think differently about what organisms are causing what we're looking at. So for the average outpatient community-acquired pneumonia that you don't need anything inpatient for, then strep pneumonia is still the #1 cause. Mycoplasma pneumonia, which is an atypical organism, Haemophilus influenza, chlamydophila, and a lot of the respiratory viruses are also fairly common. And when you look at inpatient, strep pneumonia is still #1, but you have a lot of other organisms and a lot of viruses that you can't easily differentiate from a clinical perspective, whether you're dealing with a bacteria or virus in many cases. And sometimes it's a time will tell sort of situation, whether they responded to therapy adequately or whether you got back some results, which varies depending on your laboratory support. And sometimes you don't have any. And then if you have somebody who's severely or critically ill, they require intensive care unit admission, then you're not really looking at strep pneumonia as often. It's still present, but in much reduced levels, and you tend to see other streps, Staph aureus, that should be Staph aureus. That was a little bit of a typo. You may see your Haemophilus influenza or your Moraxella catarrhalis if it's your structural lung disease cases, Legionella, but your gram negatives tend to be far more common in that setting. And so your choice of antibiotic for somebody who's admitted to the intensive care unit should provide, especially empiric coverage when you don't know what you're targeting, should provide something that is going to give you courage for those gram-negative organisms and for your Haemophilus influenza. We don't have as much MRSA or methicillin-resistant Staph aureus in Jamaica as a first world country would because of our prescribing practices and what we see, but it is increasing slowly. We are seeing more cases of Staph aureus and more cases of resistant Staph aureus. So we do have to have it in the back of our mind, especially if there are clinical features to suggest it, which I'll show you a slide on momentarily. So I thought this was a nice review from last year, looking at the responsible pathogens, and metagenomic sequencing was utilized in some of these more recent studies to identify the organism. So we're not just depending on regular culture, we're also looking at PCR and other modalities of testing for diagnosis. And if you notice, influenza virus is 46% involved in 46% of cases in the study that was done here, which was based in China on a very large population basis. And then strep pneumonia came second. And if you notice the green parts of the bars, what was notable in a lot of these cases that we had co-infection. So whether that was a secondary bacterial pneumonia on top of a viral pneumonia, or whether there were more than one organisms from a bacterial perspective playing a role. And so that's something that we have to consider. You know, empiric therapy is great, but if you can get a diagnosis for your cause, targeted treatment is going to make your treatment more effective, reduce the cost, reduce the side effects, and help you to get your patient better, faster. So, clinical features associated with specific causes. For the times where you're really floating on a wing and a prayer, you don't have your diagnostics, you need a better empiric regimen, what are some of the clues you can use? So, if you're thinking about, you know, you have a hyperacute presentation, rapid development of symptoms and deterioration, patient might present with septic shock, and you have elevated white cell counts that are quite significant with bands. The patient is septic quite quickly, and you have dense consolidation on X-ray, and maybe procalcitonin levels that are elevated, not widely available here, but they are available here in some places. Then that patient, you might be thinking, okay, Legionella, or maybe just a common strep pneumonia. Whereas if you have Mycoplasma or Chlamydophila present, or possibly even Haemophilus influenza, then you might see that there's more rapid spread within the family. Yes, well, some of this is cut out. Can we take off that administrator tag at the bottom? Patients who are not deteriorating as rapidly, they're staying a little more stable, and the white cell count may be elevated, not as significantly. No, can't get that off. Okay. So then if we're talking about viral pneumonia, you tend to have absence of all those factors that favor the bacterial pneumonia, less likely to be septic, although you can have sepsis as a feature of a viral community-acquired pneumonia, right? The procalcitonin level is a little more likely to be low in somebody who has an atypical pneumonia. Can you switch over to the other side of the slide now? Thank you. Okay, so similarly for viral pneumonia, procalcitonin levels are not as elevated, and procalcitonin has a good evidence basis internationally in the last decade for being useful to give you a clue as to whether a bacterial cause is likely. So if your procalcitonin level is over 10, then you're thinking that a bacterial cause of the patient's clinical picture is more likely, or that there's a significant bacterial contribution, as opposed to if the levels are low. If they're patchy pulmonary infiltrates, more likely to be viral. If the white cell count is less elevated, more likely to be viral. Things that I think most of you would be familiar with. And influenza is a little harder for us to target because we don't have that background environmental data. But I'm hoping that now, as COVID is decreasing, we can get back to having more reliable influenza testing being available to help us to know what our rates are in terms of what we're seeing as a trend in our background population. So if you're thinking methicillin-resistant Staph aureus, that may be because the patient has a skin eruption with pustules, or they have pleural effusion. They may have these features on X-ray, cavitary infiltrate, signs of suggestive of necrosis, significant hemoptysis. Then that may be as a secondary bacterial pneumonia on the background of somebody who already has influenza. Neutrophil count tends to be a little low, and the severe pneumonias related to community-acquired methicillin-resistant Staph aureus are thought to be more common during the summer months. We kind of have summer all year, so it's kind of harder for us to say that it's seasonal. But for us, it may be a matter of parish or location. So sometimes we see a little more of some of these more significant community-acquired MRSA cases coming from Western region or the Northwest parts of our country. And so you have to think about it sometimes depending on the patient that you have in front of you. So in terms of antimicrobial classes, just so that you have a little bit better grasp of what we're using, why and when, beta-lactams in general, they're really good drugs against a lot of germs. They can be fairly broad spectrum, and they are time-dependent killers. So the longer that the concentrations are elevated where you want the drug to be, whether it's in the blood, in the lungs, then the more killing they're going to achieve. And that includes your amoxicillin clavulanate, that includes your cephalosporins like cefuroxime, and your ceftriaxone, etc. And as you go down the spectrum for the, as you go down the class or up the class from 1st generation to 5th generation, for the cephalosporins, you're having increase in gram-negative coverage, and then you start to have better staph coverage, where at the beginning you had really good staph coverage. And cefazolin is available at the University Hospital when needed as well. So these two groups, the aminopenicillins and the cephalosporins, are our workhorse drugs for community-acquired pneumonia fairly often, especially when you're thinking about coverage for strep and some of the usual typical organisms. They inhibit cell wall synthesis. Remember the peptidoglycan layer, the thick purple beads that we were looking at? So that's where they primarily have their action. So sometimes they're not as effective for some gram-negative organisms, because remember, they have a thinner cell wall that's protected by cell membranes on either side. And in terms of dosing and duration, beta-lactams tend not to be as bioavailable from an oral dose. So when you have a severe infection, an oral therapy with a beta-lactam is not going to be possible in terms of getting something effective. So for a simple community-acquired pneumonia that's not severe, outpatient oral therapy with these is decent. But once you get something more severe, you can't take the chance of giving oral therapy in that case, okay? Because then the bioavailability is often somewhere in the 40s to 50s in terms of percentage. So you're not getting that full dose as you would with IV drugs that would go straight into the bloodstream. Common side effects, allergic reactions, because they are penicillin-based drugs or related to penicillin, and we do get allergic reactions and gastrointestinal side effects. And you will see that for most of the classes we deal with, those are two of our biggest contributors to challenges with patients adhering to therapy, other than frequency of administration or interaction with food or other things. So if you have an allergic reaction to amoxicillin clavulanate or to any of the general penicillins, you would not be able to take this, and you'd go for alternative therapy. And many beta-lactam drugs need renal adjustment. So if the patient has renal failure, you may need to adjust the dose appropriately. Macrolides, commonly used for atypical pneumonia organisms. They inhibit protein synthesis, and they have different classes according to the ring structure. We tend to have azithromycin, we tend to have clarithromycin. I will mention that between azithromycin and clarithromycin, there are some studies that suggest that the drug levels of azithromycin, although they're prolonged in the body because you have good tissue deposition, it tends to taper off over a long period of time. So you may have a prolonged period of subtherapeutic dosing, which in child studies, pediatric studies in Canada and some other places have shown that increases the risk of macrolide resistance in the community. And so for community-acquired pneumonia, for short courses of therapy, for conditions where you don't want it for its anti-inflammatory effect, sometimes clarithromycin may be preferred because it does not have that long taper, okay? Allergic reactions, again, macrolides give a lot of GI side effects. If you've ever taken it, you know what I'm talking about. They're very uncomfortable, and a lot of patients don't like them, but when you need it, and do remember that they're pregnancy category B. Fluoroquinolones. So if you have someone who's recently been on antibiotics, if they need inpatient therapy, if there are other reasons to suspect that they need a different antimicrobial spectrum, or they're allergic to penicillins, then you may be choosing a fluoroquinolone, especially a respiratory fluoroquinolone for their therapy, such as levofloxacin and ciprofloxacin. Now, nitrofurantoin, as previously mentioned, for a urinary tract infection would not be useful in the setting of a respiratory infection. So please don't use nitrofurantoin for that. But for the fluoroquinolones, as with all broad spectrum antibiotics, please remember that it does increase the risk of things like pseudomembranous colitis, of increasing colonization with expanded spectrum beta-lactamase producing organisms. Similar to cephalosporins, they also do it. And so you want to avoid broad spectrum antibiotics when you don't need them. So hopefully you know what organism you're targeting. or in the cases that you do and you don't require it, it would be better to avoid it. And of course, contraindications, if you're allergic, pregnant, lactating, if you have epilepsy, if you have QT prolongation, then you should not use them. So for tetracyclines, and this is primarily because doxycycline is often used as alternative therapy, especially for the atypical coverage or for those who are penicillin allergic, we offer, tetracyclines are generally going to be oral, and we tend to use doxycycline for this purpose. A lot of GI side effects, especially for those with, you know, a tendency towards gastritis and peptic ulcer disease. And you shouldn't use it in pregnancy and lactation. And tetracyclines are contraindicated below the age of 8 because of the effects on your musculoskeletal system. And as with most of the antibiotics we're talking about, they inhibit protein synthesis. So forgive me this very busy slide, but it was just a little summary looking at some of the antimicrobial targets we're talking about and where they act and sort of comparing them. But I think we'll skip this. So don't worry, we're winding down. I hope your brain cells are still intact. So community-acquired pneumonia guidelines for severe. Thankfully, we have new guidelines for that since 2021. There's still a little difference of opinion between the Europeans and the Americans, but a lot of this is based on European studies led by some of the professor physicians in Barcelona. And there's been a lot of review of European data more so than US data to help to guide these documents, okay? But just sort of a summary to give you an idea in terms of etiology, especially for these cases where you have severe symptoms, then a culture is recommended. Respiratory cultures, blood cultures are recommended. Bearing in mind that you may have maybe about a 50% reduction in positive blood cultures for patients who are severely ill, as opposed to respiratory culture. So you're less likely to get a positive blood culture, even when you have severe illness, in terms of versus your respiratory cultures. And you should select your microbe tests appropriately, but we have limited availability. We don't have metagenomic sequencing and all of that. So we're less likely to use things like PCR, but if it's available, and depending on the severity of illness and what factors that patient has, if you're thinking about something that's an intracellular organism like mycoplasma, or is less likely to be captured by regular bacterial culture, then you may want to consider requesting a respiratory PCR panel if available to you. And you should always do severity scoring. And please bear in mind that you can't always differentiate the non-infectious causes from the infectious causes when the patient presents. And you always have to consider in the back of your mind, you know, is this someone with renal failure or, someone who has another cause, for example, for pulmonary edema? Is this a heart failure patient who they're more cardiovascular rather than respiratory chest findings? So, you know, you have to bear that in the back of your mind, and things like neoplastic disorders. And the QSOFA is a quick scoring system similar to how we would say the SIRS criteria, the systemic inflammatory response syndrome criteria. Neither one is really better than the other. Neither one captures all septic patients in the assessment, but that's just for the utility of trying to determine early, is this person septic? Do they have a systemic response with severe inflammation related to their infection that they will need more aggressive intervention, and where time is critical in terms of appropriate intervention to save that patient's life? For antibiotic choices, we've gone through a lot of this, but compared to before, no macrolide alone for community-acquired pneumonia. So beta-lactam plus macrolide, or you can use a respiratory quinolone alone as monotherapy. You may combine a quinolone with the macrolide depending on the patient characteristics. And again, if you have severe or structural or chronic lung disease, you want to give Haemophilus coverage. So maybe your azithromycin, etc. And, you just want to try and target as best as possible. So if you can get cultures for these severe cases, get cultures. And in terms of duration of treatment, that has changed in the last decade. So we don't now treat for 7 to 10 to 14 days. If you have a simple, uncomplicated bacterial pneumonia, 5 days may be sufficient, especially if there's rapid resolution of symptoms. The patient is not septic, they're not deteriorating, they're improving steadily. They don't require oxygen therapy. So the treatment, even in the severe patient on presentation, may be appropriate as early for completion as 5 days. But depending on the patient characteristics, if they're septic, if there's poor resolution of symptoms, if the cultures show that antimicrobial therapy is not appropriate, then you may need to prolong therapy to 7 or 10 days as appropriate. And depending on the cause of the illness, and if there's something like a viral component such as COVID-19, the patient with COVID-19 who needs oxygen therapy will require corticosteroids for the cytokine response. So when not to prescribe. If you have a primary viral pneumonia and you're not really looking at bacteria, please don't give them antibiotics because we want to preserve the utility of them as long as we can. And if it's not coming to acquired pneumonia, you end up with a patient who's in acute pulmonary edema, you deal with their other issues and they settle down. That's not somebody who needs antibiotics. Sometimes you can't determine them in the beginning and you give them empiric therapy, but that means then you want to de-escalate and take it off when it's not needed. You don't have to finish that 7 days because you started it. If it's not necessary, you can remove that from your therapy, okay? So, antimicrobial stewardship. We're getting to the end, guys. We really want to reduce antimicrobial resistance to preserve the effect of the antibiotics we do have, to reduce the side effects on the patients, including things like damaging their normal flora, which is protective, including things like increasing the risk of side effects like C. difficile-associated diarrhea, etc. So we want to be good stewards of our antimicrobials because there are very few of them compared to what we need. And there are incidences in the last decade, increasing incidences of infections that we can't treat with any of the known antimicrobial agents. Okay, and that's happening particularly with things like gonorrhea, which is not a respiratory disease, thankfully. But, these things are happening more and more. So we kind of have to pay attention. So how are we going to do that? Appropriate antibiotic selection, the appropriate dosing regimen so that it's effective, the appropriate duration of treatment so that we don't go overboard or under treat and lead to greater resistance, and prescribing it when it's needed and not prescribing it when it's not needed. And really the most important modifiable risk factor is, as you see here, if we can avoid inappropriate prescribing of antibiotics, we can save a lot of people, a lot of problems. So the right drug for the right patient in the right time frame. And longer treatment or a more high-powered drug is not necessarily better. You want targeted therapy when you can to attack the germ you're after and leave the other germs alone. Leave the other people. Less collateral damage is better for immune function because your normal flora protects you from the germs you encounter. So you want to preserve them. Okay, so please remember to de-escalate when appropriate and get rid of the antibiotics or adjust to more targeted, narrower spectrum therapy when you can. Not always possible, but when you can, because each time you do that, you're saving efficacy for a few more people. Last thing before we summarize and review. So strep pneumoniae, it's still one of the top contenders. And from a bacterial perspective, it's still #1 in terms of the rates of infection for community acquired pneumonia. And pneumococcal vaccination, I couldn't go through without mentioning that pneumococcal vaccination has changed the impact of strep pneumonia and invasive pneumococcal disease. And so if you look at this between the introduction of the 7-valent, not the polysaccharide vaccine now, but the conjugate vaccine, 7-valent one, we had a rapid fall off on what were the primary contributors to invasive pneumococcal disease. Then after the introduction of the 13-valent, we had continued maintenance of those more virulent types of strep pneumonia, and we had fall off in others that had increased when the biggest, baddest ones got out of the way. So pneumococcal vaccination is helpful, especially in those over 65 and for children. So we should not forget about that when you're evaluating your older patients, they're transitioning, they may need a new look at their vaccination status. And so in summary, we have lifestyle associated risk factors that increase the risk of community acquired pneumonia, possibly also increasing the risk of severity. You have comorbid conditions that increase the risk of pneumonia by 2 to 4-fold as well, and that can also mean increase in severity. And we want to really be as targeted as possible. We want to test those who are going to be more severe or need admission, and we should carefully consider alternative treatments if the etiology is looking like something other than the typical strep pneumonia and your atypical agents. And so, you know, we should also use the things like the CURB 65 if we can to help us stratify. And remember that there are things that may not be infectious. It may not be community acquired pneumonia. And so we have to have that in the back of our mind and de-escalate from empiric therapy when we recognize that pneumonia is not the primary reason for the patient being ill with their respiratory symptoms. And be narrow and targeted, and stop smoking if you can, or get your patients to stop smoking if you can get them to stop. It makes a big difference. It's one of the biggest lifestyle risk factors that we can have an impact on. So just to remind you, initial treatment regimens for outpatient therapy, if there aren't any risk factors for methicillin-resistant Staph aureus or Pseudomonas as a gram-negative organism, there aren't any of the comorbidities you see on the next slide, then these are the appropriate choices and doses. And remember, we talked about duration. So 5 days may be appropriate. And then if you're talking about patients with comorbidities like alcoholism, they're functionally asplenic, diabetes, malignancy, and chronic organ diseases, then your choice of antimicrobials may need to be adjusted to something more targeted to those particular risk factors. And those are my references. So I don't know if you have any questions. We seem to have a question over here.
Right here.
Too many previous marathons.
Right, thanks for excellent presentation, Doc. In the workup, just prior to treatment, are there any times that you would use lactate levels?
Well, lactate levels tend to be useful in the more severely ill patient because you're really looking at somebody who needs more intensive support. We tend to use them in intensive care unit patients much more commonly than we do in the average community acquired pneumonia, because if they're not severe, that really might not change your thought process. And it really has to do with tissue perfusion. So that may be useful, for example, in the septic patient who may not be perfusing. Right, right. So, you know, the Q-SOFA is helpful for sepsis. And sepsis is what we're really talking about in that situation. And increased lactate levels with poor tissue perfusion is common in sepsis. So it's like a marker to say, hey, you should consider sepsis in this patient if you were not already considering it.
Hi, Kathy. You spoke about the duration of treatment
Mhm.
for persons who are not necessarily severely ill, moderate to severe, CAP. Is there a consideration of not just the severity of disease, but the age of the patient and other predisposing factors to determining whether or not use 5 or 7 to 10? And the other question is, does the dose of the beta-lactam antibiotics, would it vary if you were going to do 5 days versus a longer period?
So we don't, I'll start with the last one first. We don't necessarily change the dose of a beta-lactam if you're changing duration of therapy. Dosing adjustments tend to be with macrolides. For example, you have a common confusion. Pharmacists complain a lot about the use of azithromycin, that people will ask for 5 days of 500 milligrams, which is not really required. It's a little bit of overkill, because 3 days of 500 milligrams or a 5-day course of 250 or a course of a 500 stat dose and 4 days of 250 are often the recommended regimens if you're using azithromycin for that. But for the beta-lactams, the dose adjustment like that might only be with amoxicillin clavulanate. You might use a 625 milligram dose for a very mild situation for maybe a smaller bodied person. But once you're considering that there are enough signs of severity that you don't want to do a lower level of therapy, you're going to do 1 gram if you're going to give oral therapy. And for the average adult, we really have moved away quite a bit from a 625 milligram to 1 gram, and particularly also because of changes in resistance patterns. So from that perspective, the first question you asked was about right. So if you have somebody who is more vulnerable or has a less robust immune response, which age is also one of the risk factors for that, you may consider a 7-day course, a 10-day course. But what's always recommended in the last sets of guidelines is that you reevaluate the patient by day 5. Because if you have someone who's rapidly improving, you may not, and who has had decent resolution of symptoms and signs, even though they may be considered more vulnerable, they may not require a prolonged course of treatment. So in terms of duration, we're moving towards recommending it be more individualized based on a reevaluation, as opposed to giving a standard duration of therapy and, saying, okay, this is good, go with Jesus and you're okay. Any other questions?
Oh, thank you for the excellent presentation. I was just asking, as it relates to procalcitonin levels, how available it is publicly, and just to re-ask, you said it's if it's over 10, used to be able to tell viral versus bacterial.
So it is available in some of the private labs. There are kits available from some of the companies. And so from time to time, the intensive care unit at the University Hospital will do testing with kits, or they have a machine that they will use from time to time. Supplies are part of the challenge, and it always comes at a cost, but it is one of the more useful things. So you really have to check with the lab that you use often if they have it available. More often than not, it has been available more recently, but with the supply challenges we've been having, that can be difficult. And usually if you see a level of 10 or higher, then that suggests that there is a bacterial component to that patient's illness. It's not an absolute rule, and sometimes it is also useful in terms of just looking for that as a contributing factor, but it's not something that necessarily you could use for monitoring. For example, you wouldn't say, okay, well, it's over 10 now, and 5 days later, okay, now it's below 10, so we're good. Can't quite use it like that, but it is helpful when you're trying to determine, should I be more concerned about a bacterial infection in this person whose symptoms are a little overlapping and it's harder to tell? Because sometimes the inflammatory response has nothing to do with either a bacterial infection and sometimes no infection at all.
Thank you so much. All right, so we're going for some questions online. The first question from Professor Durrani: when do we put persons on ventilators?
On ventilators,
Yes.
when they have respiratory failure. I'm not trying to be feisty, dog. Okay,
Yes.
so you really would be putting someone in the intensive care unit if they need a more critical care level of monitoring and support. They may have impending respiratory failure, but you're really going to use a ventilator in the setting of respiratory failure if non-invasive ventilation is not an option, or if there's failure of non-invasive ventilation or it's not available. But once that person is able to breathe and maintain their oxygenation systemically, then you would be trying to get them off of that, or you would not be considering ventilator use.
Thank you very much. Dr. William Brown, any clinical confirmation of combination prescriptions of amoxiclav and zithro in positive COVID-19 patients?
So over the last 3 years with COVID-19, we started with a lot of antimicrobial treatments, some for inflammatory purposes and otherwise, but the evidence really has not been supportive that antimicrobial prescriptions are helpful, and they may be deleterious. We have seen an increase in things like C. difficile associated infections and other side effects of antimicrobial use that may not be beneficial. And even though at one point we said, well, azithromycin may be anti-inflammatory for COVID-19, honestly, with everything that I've reviewed of data and what I've seen at work, antibiotics, generally speaking, in COVID-19 are bad unless you have a secondary bacterial pneumonia.
Thank you so much. The next question I'm seeing here: in the outpatient setting, when CAP is suspected, cough with colored sputum, fever, etc., do we send the patient for chest X-ray and then start empiric treatment? Or do we start immediately, since we may only see the patient once?
If you're, well, I'm going to answer that in a bit of a roundabout way. If you're really concerned about the patient's safety in that situation, you would want to advise them that if they get any worse, they seek care immediately, even if they don't come back to you. But you would not withhold empiric antimicrobial therapy for a chest X-ray. If you have clinical signs of consolidation, you have enough clinical evidence to have a decent suspicion for a bacterial pneumonia, and the patient has all those things that you're talking about, and there isn't an underlying disease that could mimic all of those signs of a pneumonia, then you should start your empiric therapy. The X-ray may be helpful, and you should request it, but you shouldn't delay antimicrobial therapy to get an X-ray. The main reasons that we would say, okay, don't give the antibiotics this minute, do this test first, would be for cultures when we want to get targeted therapy. So if you can get a respiratory culture or blood culture or both for a patient who is looking more acute or hyperacute, maybe more severe, and may end up in hospital care, then the best time to do the cultures are right away and start right after. So sometimes you would give the patient the prescription and say, and the lab form, and say, please go to the lab and get this test done before you start the first tablet, but get the tablet on your way and start it as soon as you do, so that you have something to fall back on if treatment is not going as expected or the patient is deteriorating. Because after you start antibiotics, it's going to be very hard to get an answer, most often not.
Thank you very much. Many persons have switched from cigarette smoking to vaping, thinking that the latter has less side effects on lung function. After all, it's only steam. What is your view on this?
So based on the evidence that I've seen coming out of vaping studies, Vaping is not benign. It does cause lung damage. It may not cause the same lung damage as smoking, but it does cause damage to lung tissue. And the other side of it is the effects of nicotine are the effects of nicotine. There are effects on the circulation, on cardiovascular health, on other issues. So if you can avoid both of them, you should avoid both of them. It is sometimes considered a lesser evil, but if you are one of those people who develops lung disease from it, you really can't go back. The damage is already done.
Thank you. I think there's a follow-up. Does the same hold for marijuana?
So, not for Joanna and Mary, but so for marijuana, there is a matter of the drug effects and in terms of chemically, and there's a matter of how you imbibe it. Smoke particles deposit in lung tissue and they cause biochemical and structural issues. So smoking of any kind is going to put unnecessary chemicals and particles in your lungs that you don't want, that will be less likely to be removed, either by your body, that tend to be sequestered and stored there, as opposed to coming back out. So smoking generally, despite not having tobacco in there, is going to have some deleterious effect. But the issue with marijuana, separate from how you use it, may be your unique mix and whether there's a lot of THC or a lot of cannabinoid in there. So the chemical composition in Jamaica, we tend to prize our marijuana for its THC and psychotropic components because people want that feeling. And that is not necessarily helpful from a medical perspective. The cannabinoids by themselves have better data for a lot of health conditions. But for some types of epilepsy, some neurologic syndromes, varying proportions of THC and cannabinoids may be useful in one or the other. So it really comes down to what does your body need. If you're smoking it, that's pretty much the worst way to take it in.
Thank you very much. Iraman. In a setting where directed testing is not available, how do we suspect viral pneumonia, and what would be the best course of action if it's not possible to differentiate?
So you have to really start at your history. Is it somebody who had respiratory environmental exposures, had contact with somebody who was ill? You know, is there something going around at work or at school? Is there less, you know, are you having higher fevers? So temperatures that are up in the 40s tend to be more viral or centrally mediated and less bacterial associated. If your white cell count is not significantly elevated, especially with a neutrophilia, if you are not having a lot of consolidation, sometimes the X-ray picture is a little more patchy infiltrates as opposed to a more consolidated picture, either on examination or in radiologic features. So it varies. Forgotten the second part of the question, sorry.
Sorry. The second part of the question was?
How do you treat viral? Supportive therapy mostly. If you have influenza or if you have a severe viral picture, then once it's influenza, you can give oseltamivir. We do have Tamiflu available through the Ministry of Health. It's at hospitals. It has to be started early in treatment. If it's not started within, say, 72 hours, the effect really may not be beneficial. But it's the only targeted antiviral that we have against respiratory viruses, and it really is for influenza. It's not going to have any significant effect on the others. So for the non-influenza respiratory viruses, it really is primarily supportive therapy. things to reduce any comorbid illness contribution, to support their respiratory function, whether that means oxygen therapy if it's needed, whether that means physiotherapy, whether that means something anti-inflammatory, mucolytic, better hydration, so the mucus is not as thick and doesn't stay in place and block the passages, treating underlying lung conditions like asthma to reduce bronchoconstriction, and all those other supportive measures, whether that means also using things like vitamin C and zinc to try to help boost enzymatic and immune function. Hydration tends to be one of the most important things because the average person doesn't drink enough water.
Thank you very much. All right. Is CAP a leading cause of death in Jamaica? Are most cases successfully treated outside of the hospital?
Honestly, our data is a little scanty, so it's hard to answer that question. We don't have as robust demographic data for community-acquired pneumonia, especially when you're trying to differentiate outpatient care in the private system versus inpatient care. So I can't really answer that. But in terms of it being a leading cause of death, it is still up there in our top causes of death. It varies from time to time. Sometimes diarrheal illnesses might be a little up, depending on whether you're talking about adult or pediatric population. COVID-19 changed a lot of things. I don't know that we've had a good review in recent times, especially in the last 2 years, looking at where we're at with community-acquired pneumonia. But if you take COVID-19 into account as a viral cause of community-acquired pneumonia, then it's been one of the more significant contributors. Not necessarily number one, but it's been up there in the top 10.
All right, thank you. So we have two final questions. First, we'll go to one about pediatrics. What is your advice in the use of antibiotics in the pediatric population in the treatment of bacterial pharyngitis and pneumonias?
So let me first state I'm not a pediatrician, so I don't really deal with children, but, but generally speaking, if you have a bacterial pneumonia, you're going to use antibiotics, whether it's an adult or a child, because the immune system may not be able to get over that infection. Bacteria can be difficult to deal with. In terms of more details on that, you really need to ask a pediatrician. I'm not the best one to answer that one, but generally speaking, as a sort of general rule, the same features that would make you think bacterial infection, the same features that would make you think sepsis are going to cause you to require antimicrobial therapy. And, you know, people tend to freak out a little bit more at the thought of a child dying. So they're often a little more aggressive, but the same general principles apply. If you find out that there is significant, you know, there are significant features suggestive of a community-acquired pneumonia, you're going to treat empirically until you get back your results or you determine whether that is the case, and you're going to de-escalate when possible.
All right, thank you very much. Ladies and gentlemen, please give a round of applause to our presenter. Okay.
Thank you so much, Dr. Pate-Robinson. And thank you, audience. And thank you, audience, in person and online. And right now, we've been doing very, very, very well as it relates to time, and we want to keep it that way. However, we understand that nature calls, and as such, we're going to take a quick 15 minutes break and allow persons to, you know, kind of get themselves together and come back. So during the interim, we will be just placing some videos online so that you can occupy your time or go do what you need to do. All right, thank you so much. We'll be back soon.
welcome back. Thank you guys so much for taking that break. We really needed, really needed, sorry. All right, so ladies and gentlemen, online, you are here. We want to thank all 800 plus of you for being online. You have, oh wow, round of applause. You are automatically entered to get your CMEs. You don't need to request it. And the post-test, being a post-test, will be shared at the end of today's webinar. And so I hand back over to you, Nakia.
Thank you so much, Sam. All right, so we're back. Thank you for staying with us. And of course, we are into our last session and our final presentation. And of course, we have to mention our sponsors, being Sandoz. And these sessions were brought to you by our Sandoz line, or antibiotics line. Of course, Curam, Bionazid, levofloxacin, Zinat, which most of you haven't heard is now a Sandoz brand. And of course, our ceftriaxone, our injectables. So with that said, the meeting has been going really fast. And so expect to finish a little bit ahead of time. So without further ado, I will invite my able colleague, Mr. Wayne Young, to do the introduction of our final guest speaker. Wayne, over to you.
Thank you, Mr. Rowe. Good after morning, everyone. Good after morning, everyone. It's still morning. Good morning, everyone. Wonderful. I'm hoping this break brought some life back to you guys and we are not sleepy right now. Hopefully not too much sugar. Might have to give you some antibiotic based on what's going on. Everybody gets it. All right, so we are down to our last presentation. And unfortunately, our speaker wasn't able to be here physically. However, she'll be presenting online, all right? Okay, so Dr. Thoms-Rodrigues was born on November 5th in that blessed year. She completed her bachelor's in basic medical sciences at the University of the West Indies in 2004, her MBBS at the University of the West Indies in 2006, and her doctorate of medicine in microbiology in 2013 from the University of the West Indies. She's currently a lecturer at the university and a consultant microbiologist at the University Hospital of the West Indies. Dr. Thoms-Rodrigues is primarily involved in clinical bacteriology, where she participates in the daily operations of the diagnostic laboratory and provides consultations on patients' management. She's a member of the University Hospital of the West Indies Infection Control Committee and is involved in the daily activities aimed at reducing the spread of healthcare-associated infections at the hospital. Dr. Rodrigues has done several online courses to keep abreast and current with global changes within healthcare. Her most recent being Infectious Diseases in Adults at the Harvard Medical School and Massachusetts General Hospital. This was completed in 2021, as well as Mold Identification online course, which was offered by the Center for Disease Control and Prevention, completed in 2021 as well. Her main area of research is on antibiotic resistance, and she has conducted several studies in this area. She has done several peer-reviewed publications during the period 2010 to 2022, where she was either the lead or co-author. Her most recent publication coming in 2022, her paper entitled Cryptococcemia in a Jamaican Cohort. This was peer-reviewed and published in the Caribbean Medical Journal on March 14, 2022. She was the lead author on this paper. Dr. Rodrigues is a member of the Caribbean Association of Microbiologists and is the American Society of Microbiology Young Ambassador to Jamaica 2020 to 2022. Dr. Thoms-Rodrigues' area of specialization deals with medical microbiology with special interests in infectious diseases, antibiotic resistance, and control of healthcare-associated infection. So it is therefore fitting that she presents on the topic, Emergence of New Trends in Antibiotic Resistance. Please help me welcome Dr. Camille Thoms-Rodrigues.
Thank you. Thank you very much, Mr. Young, for that very kind introduction. I'm going to share my slides just a minute. I'm hoping everybody is able to see my screen. I'd like to also thank the organizers of the conference for this opportunity to present my topic entitled Emergence of New Trends in Antibiotic Resistance. And without further ado, we'll get right into it. I have no disclosures. So this is the outline that I'll be using for today's presentation. 1 second. I'll be looking at antimicrobial resistance, the causes of same, the implications of AMR. We look at COVID-19 and antimicrobial resistance as we contemplate new trends in AMR that have emerged since then, as we consider the topic, new and emerging trends in antimicrobial resistance. Some mechanisms, although they have been around from say the 1990s, there have been newer genes discovered, or perhaps the extent to which we are seeing it in our own population is what makes it novel or newer and emerging. So we know that bacteria have developed resistance to evade the action of antibiotics. About 6 decades ago, this was not the case, and it has not been fully determined how these genes emerged. We know that bacteria can either be born with resistance genes on their chromosomes, or they can acquire them on mobile genetic elements. And those two, the acquisition of resistance can also be as a result of mutations that can happen within the chromosomes. And there are methods by which, through high frequency conjugation, you can have the exchange of chromosomal genes as well through plasmids. And so in short, whether or not the organism was born resistant or it acquired it on a plasmid, regardless of where the gene is, it can be shared, the mechanism can be shared. And that's problematic because then over time, more and more organisms, some that perhaps didn't know how to become resistant to a particular drug for which you had a particular tool for treatment, they can also become resistant, leaving us with very little in our antibiotic armamentarium for treatment. I think most persons by now would have been familiar with what some of the factors put forward as being responsible for this problem. And ultimately what is theorized is either that using the antibiotic too much will give the organism a chance to be exposed and to mutate and to become resistant. And their ability to survive having been exposed is compounded or is made possible when a suboptimal course is given. Therefore, overprescribing antibiotics, using them when not necessary, not finishing the therapy as prescribed by the clinician, linked to overprescription in hospital is our overuse of antibiotics outside of the hospital in veterinary medicine, in agriculture, for example. And then on top of that, when we have drug-resistant strains present, we try to contain them using infection control measures. And when these fail or when these have broken down, it's much easier for the organism to spread within the institution to other patients, to other organisms. And this too is linked to a lack of hygiene and poor sanitation. So we're having this problem wherein we have all of these risk factors promoting the emergence of the organisms, and that alongside the fact that fewer new antibiotics are being made to try and counter them. And so, of course, in the end, we have a net increase in resistant strains. Another thing to consider is the impact of our use of antibiotics on selecting for more resistant organisms. Okay, so we know that a lot of the genes that these organisms carry, it's cumbersome for them to carry it. So when conditions are favorable, they'd rather not hold on to this gene. And so oftentimes that's why within the hospital where the antibiotic pressure is higher, we tend to have more resistant organisms. But we have our normal flora who will try to compete for nutrients and keep at bay some of our more resistant strains. But when we begin to use antibiotics, and hopefully we would start at the lower spectrum, We will kill off the more susceptible wild type strains, normal flora strains, or even pathogens, but those that are susceptible, that would have been shown in blue, that would leave behind our more resistant bugs. And now the next set of bacteria to proliferate and predominate would be those that are resistant. And so the next infection is likely to be a more resistant one, and it gets worse and worse over time. So you really want to try and stay at bay the use of antibiotics for as long as possible. We see it a lot in patients who are in hospital for a long time. They start off with very sensitive bugs, especially when they end up in ICU, and over time, we're getting more and more resistant bugs until there's one that is perhaps whether relatively or absolutely drug resistant, and there's nothing available for treatment. I spoke about spread. We can talk about it at the level of the bacteria in terms of the three main mechanisms that it uses, whether through conjugation or they use a virus, a bacteriophage, to spread the genes. But I want to also point out that when bacteria die, it's easy for other bacteria through transformation to just pick up the gene that's hanging around, or the genetic information that's hanging around, including drug resistance information. And so there are a number of ways that organisms can arm themselves to become resistant to antibiotics. And in terms of exposure to our patients and spread within the human population, we know that when persons interact with the healthcare setting where we're more likely to have more resistant bugs, the chances of acquisition would be greater. And also, we now have to contemplate with the use of antibiotics outside of the hospital, in veterinary medicine, in agriculture. So the meat that you might be handling may have multi-drug resistant strains, your pets. And so you can pick up these organisms in this way as well. So what has been created over time and continues to be created is a perfect storm, where we're seeing an increase in drug-resistant organisms over time with fewer and fewer antibiotics being made. Drug companies would find it harder to invest in a drug which, after hitting the market for only just a few days, resistance has emerged. You're no longer able to use it as much. You're no longer able to recoup funds. And so we're not getting a lot of antibiotics put forward. And the organisms are not just sitting back and taking our jabs. They are counter jabbing, they're counter hitting. And so as soon as a new antibiotic is put out, you can just look out for a report on resistance. So already, even some of the novel drugs that have not yet hit our shores, drugs like your carbapenems with beta-lactamase inhibitors, which we'll talk about later, already there has been a report, or there have been reports of resistance already emerging. And we live in a global village. So, resistance in one place is really resistance in all places, ultimately. So we really do have a crisis on our hands. It is somewhat of a silent pandemic, which occasionally gets some light shed on it, but it's a problem that continues to go on. And because sometimes the patient may initially present with something else, but end up with this superimposed infection, a lot of the times people don't connect the dots to say, ultimately, even though this patient may have had other comorbidities, what really took them to their grave was a multi-drug resistant bug or a pan-drug resistant bug in the end that we really could not treat. So this is a wonderful opportunity for us to be reminded about this crisis, which has been highlighted by various periodicals as shown, and societies who have launched campaigns. Now, there are a number of different drugs, and of course, a number of them being resistant, and therefore having resistant patterns, mechanisms in different organisms. But there are about 18, some of which are shown here. There are more now on the urgent level, which I'll go into later on, that based on their impact on human health have been prioritized and are the focus of the discussion. These organisms, which are often dubbed superbugs, have been put into threat levels by the CDC, the lowest being the hazard level concerning, where we find organisms like vancomycin-resistant Staphylococcus aureus. And for some reason, I don't know why, even though we use the vanco, perhaps because we're not using it as much, it's nephrotoxic or ototoxic, and once staph is methicillin susceptible, your second generation penicillins are better than vancomycin for treatment. But we have not seen a lot of resistance emerging to vancomycin. So much so that if you do a test in the lab in vitro, if you see vancomycin resistance, we never believe the first test. And oftentimes when we repeat and we check it, it's really not resistant. It's just not common. In the same way that we're noticing that most of our beta hemolytic strep, like group A strep, for whatever reason, they have remained uniformly susceptible to penicillin, which most other organisms have already become resistant to. Perhaps that's something that we need to study to help solve the problem we're facing with antibiotic resistance. However, among our group A and group B, streptococci, what is of concern is your macrolide resistance and clindamycin resistance, respectively. Unfortunately, there is not a lot of data. So I know a lot of persons would have been contemplating the use of ceftriaxone and azithromycin a lot during the pandemic. And unfortunately, the data in terms of what has happened with the macrolide resistance rates just is not yet put out by the CDC. But we look at some of the other things that they have been reporting on. We have our serious hazard level where we're finding things like MDR Acinetobacter. Now, when the Acinetobacter has become carbapenem resistant, we dub that carbapenem resistant Acinetobacter CRAB. That now is on the urgent level. Quite problematic. And interestingly, Acinetobacter is like the coagulase negative staph of the hospital. But when it is drug resistant, it really is a real problem. And we've been seeing some cases at the university hospital that are essentially pan-drug resistant, because in vivo, if we even get some hint of susceptibility to colistin, some of the infections that we may want to use it to treat, it's not an ideal option for therapy. MDR Pseudomonas, of course, if it becomes carbapenem resistant, then it's even more problematic, would be on this level. Or ESBLs, which have emerged and are predominating in some settings. I think probably most persons would have encountered an ESBL at least when dealing with patients. So we definitely need to be comfortable with recognizing them, especially in areas where laboratory support is not as strong, and knowing we need to discuss what treatment options would be appropriate. So we're going to spend some time talking about the ESBLs. Most persons would have met Marsha, my colleague, shared with you that our rates have remained low, certainly not a lot in terms of published data, but when we looked at it, we've really had some low rates, which is quite unusual compared to other countries, but we are grateful. VRE rates also very low, like less than 1% when we last checked, etc. I'll also mention the problem of our multi-drug resistance and extended drug resistant tuberculosis strains, candidal infections, which are emerging. And also we see it a lot too when the patient has been on broad spectrum antibiotics. And so we would have killed all of the bacteria and a fungal infection will now emerge. So this now is definitely something that we want to take a look at and keep our eye on. And then on our urgent level, I'll start with cephalosporin resistant Neisseria gonorrhoeae. This one is setting to become one of the first bugs against which we have no antibiotics waiting in the pipeline to treat it. And we know that it can get gonorrhea many times. Over the years, we would have started using penicillin to treat Neisseria gonorrhoeae. Then we had penicillin producing Neisseria gonorrhoeae. Went to the tetracyclines and quinolones. Resistance emerged, went to the cephalosporins, and now there has been reports of resistance initially to cefixime, which is the oral third gen. They've pulled cefixime as a recommendation for first-line therapy, left the ceftriaxone. The worry was that the resistance to the cefixime would disarm the ceftriaxone. So the ceftriaxone now is essentially the main man standing. Some sources recommend adding azithromycin to it to kind of preserve its life. But there needs to be more in terms of production of new drugs for the treatment of this bacteria. Another big problem is our carbapenem resistance. I'll say bugs in general, but certainly our Enterobacteriaceae, which includes organisms such as E. coli, Klebsiella, Proteus, Shigella, and so on. they have become carbapenem resistant. And when you look at our beta-lactams, which would have included our penicillins, our cephalosporins, our carbapenems were like our nuclear weapons, our M16. They were the high-powered options. So when you're seeing resistance to them, it leaves very little left in terms of high-powered, non-toxic, broad-spectrum, suitable options to treat our patients, especially our septic patients. And oftentimes they succumb to these infections. So we really do need to join in the fight against these, where carbapenem use is not restricted in healthcare settings. Perhaps this needs to be considered and AMS antimicrobial stewardship policies put in so that we can preserve their life. We need to check, we need to be doing surveillance, and we need to be isolating these patients. Clostridium difficile, which can be drug resistant, is also one to watch on the urgent threat level right now. There are just a handful of drugs available for therapy. Vanco has become the drug of choice, oral Vanco slurry, and I'll talk a little bit about our experience with this later on. So then, what has happened since the pandemic? I'd like to quote Whitley as saying that the bitter truth is that the COVID-19 pandemic is just the tip of the iceberg, as a real danger with the potential to sink the world is antibiotic resistance, which is looming in the darkness. And a respected colleague shared that you would notice that patients would have overcome their COVID-19 infection only to die from an antimicrobial resistant organism. So the problem continued, it was always there, and it is still rearing its ugly head and continues to rear its ugly head. And we know that with COVID-19, there was a lot of, well, more use of certain antibiotics in hospital. One may argue that there wasn't a lot of use in the outpatient setting. Patients weren't going out as much. And so there was that. But certainly in the hospital setting, we saw an increase in the use of antibiotics, especially empiric usage. So that's even more tricky in terms of just not knowing whether or not the drug is suitable. Fewer resources being expended on surveillance for AMR, etc. And so this definitely had an impact on antibiotic resistance. For some organisms, the CDC reports have increased in the threat estimates, which we will look at later on. In terms of the impact on mortality, and I have a nice graphic that will come later, we're seeing that AMR is projected to be responsible for approximately 10 million deaths worldwide in the upcoming 30 years, as per the pre-COVID-19 analysis, surpassing death due to cancer, diabetes, and other factors. So coronavirus disease soared the usage of pharmaceuticals and personal care products. We know that definitely the use of ceftriaxone with azithromycin has been used a lot. There's also a long trail of biomedical waste and biocides. And they've been noticing that in our wastewater systems, that has now become an important reservoir for carbapenem-resistant bugs. So when we look at waste as well, we have to consider what we're putting down our sewage and, the kind of antimicrobial resistant organisms there that can be proliferating, released into our environment, into our soil, and our animals would then eat vegetation and so on that would be colonized with these organisms. So a realistic potential of increasing global AMR, the global AMR burden is anticipated, and the cumulative harmful effects on human and animal health and the environment is thought to be inevitable. And this was the graphic I made mention of, that showing the fact that AMR is accounted for a significant number of deaths compared to other significant illnesses. So it's definitely one to watch. All right, so this is a report of threat estimates in 2022, a 2022 report from the CDC. Now, I'd mentioned that organisms are within the urgent, serious, and concerning threat levels. I'm just going to focus on the urgent and the serious, some of the organisms in the serious threat levels. The data, as I told you, for your macrolide and clindamycin resistant organisms, that was not yet available due to the pandemic. All right, so we'll begin with our carbapenem resistant Acinetobacter. And we just look at the 2019 third estimate where they thought you would get about 6,000 cases with 500 deaths. And in short, this is expected to increase. There's an overall increase being estimated post 2020 of about 35%. And in terms of hospital onset cases, as high as 78%. In terms of your other carbapenem-resistant bugs, your carbapenem-resistant Enterobacteriales, which would include, again, your E. coli and so on. Those are actually on the downward trend in 2017 to 2019, but we've now seen an increase in hospital onset cases post 2020. C. difficile data is delayed, as well as that data for Neisseria gonorrhoeae, but just want to point out that there is this new-ish yeast on the block, very dangerous drug-resistant Candida auris, and they were seeing an increase in 2017 to 2019, and this continued post-2020. We had a scare, but so far, our mycology lab, which I believe is the only one in Jamaica and likely the Caribbean, we've not had any cases reported since that scare. In terms of the organisms on the serious threat level, I want to just zero in on our ESBLs, which we're going to talk about. Definitely problematic. There was an increase in 2017 to 2019, and this continued post 2020 with an overall 10% increase, and in terms of hospital onset, 32%. The other Candida, which can be drug resistant, are also problematic with an increase seen post 2020. We don't have a lot of VRV cases locally, but they were reporting an increase as well post 2020. And drug resistant, well, for Campylobacter, that data was delayed, but before the pandemic, there was an upward trend. So I thought it worthwhile to just take some time to look at some of the resistance mechanisms mentioned there and their impact on the antibiogram. I'd focus more on the gram negatives, which often use drug inactivating enzymes as their main mechanism of resistance. So I'm going to talk about some of the drug inactivating enzymes that affect beta-lactam antibiotics, mainly our ESBLs and AMCs, as well as our carbapenemases, and then quickly look at some of the others. So this is how we classify the various beta-lactamase enzymes that can and have emerged to the various beta-lactam antibiotics that have been made over the years. Our ESBLs are extended spectrum beta-lactamases that target all penicillins, cephalosporins, monobactams, but they are inhibited by clavulanic acid. I thought it useful to then also contrast that to our AMC beta-lactamases, which have a similar look on the antibiogram with some notable exceptions. They are inhibited by clavulanic acid. Okay, they target your third-gen cephalosporins, your penicillins, your monobactams, but they spare the fourth. They target your kefamycins as well, which are the screening antibiotics. So we look at them in parallel, sort of. And then we'll talk about our carbapenemases, which have been found in different classes. So our ESBLs, there is no consensus on a precise definition, but a commonly used working definition is that these are beta-lactamases capable of conferring bacterial resistance to all our penicillins, first to third generation cephalosporins and some fourth, like kefepime, astronam, or monobactams. It spares our kefamycins like cefoxitin, and they're inhibited by clavulanic acid, not just clavulanic acid, but other beta-lactamase inhibitors with activity against them, like Tazobactam. Our AMCs, as I mentioned, also degrade penicillins, your extended spectrum cephalosporins, but not our fourth generation cephalosporins, like kefepime. They also degrade kefamycins, monobactams, and they are not inhibited by beta-lactamase inhibitors. They can be chromosomal as well as plasmid mediated. So we'll talk about this, where some organisms are already carrying this, some as a hidden weapon, whereas mostly our ESBLs are plasmid-borne, plasmid-mediated. Detection of our MC organisms are difficult because their presence does not always produce a resistance phenotype during doing our susceptibility tests. Okay, so there are some organisms then that if you know they always carry the gene and they carry it as a hidden weapon, when you get that on your report, you're treating your patient with that in mind and monitoring them very closely. So these enzymes are often associated with potentially fatal laboratory reports of false susceptibility to beta-lactams phenotypically. And with the worldwide increase in the occurrence types and rate of dissemination of these enzymes, their early detection is crucial. So those bacteria that can carry the MC gene on their chromosome, meaning they're born with it, but they hide it. They don't turn it on, they don't express it until you've begun to use beta-lactams, are loosely referred to as spice bugs. That's one acronym. Another is SPACE, or MCs, which we'll see later. The S stands for Serratia marcescens, and I'll just take the opportunity to say, one case of Serratia marks a breakdown in infection control. So that is something worth investigating. Pseudomonas aeruginosa, or P, or indole-positive protein like Proteus vulgaris, or I, Citrobacter species, or C, and Enterobacter cloacae, or E. So these colloquial acronyms are for organisms that carry the gene on a chromosome, but it's an inducible gene. It's not always expressed, but turned on in circumstances where it's necessary, and that's when you start to use certain beta-lactams. They are not more virulent than their susceptible counterparts, it's just that they're more resistant. The graphic on the left, if you focus on the section for gram-negative bacteria, shows this sort of grouping, or the fact that our MCs can be chromosomal or plasmid mediated. Well, here for the plasmid mediated, they're focusing on the ESBLs, but you can have plasmid-borne MCs. And on the left, we see that our C-beta-lactamases, which are in our group 1 classification, can be inducible. That's our spice bugs, but there are some that can have it on the chromosome and express it all the time. And I told you that we can use a different type of mnemonic space where the A stands for Acinetobacter where it occurs, or MCs, the M, Morganella, which is a protea within the Proteae family, Pseudomonas, Citrobacter, Enterobacter, and Serratia. So in simple terms, if we're to look at our antibiogram, then our ESBLs would look something like this: susceptible to ampicillin, but not augmentin, susceptible to my second generation, and if I tested my first, so cefuroxime, some of my third, ceftriaxone, ceftazidime, my fourth, cefepime. Not going to affect our cefamycins or carbapenems. Whereas for our MCs, they are not inhibited by the beta-lactamase inhibitors, so they are also resistant to augmentin. They can also degrade the cefamycin, so they're resistant to cefoxitin. The only thing is that they spare the cefepime, so you can get away with using a fourth generation cephalosporin if susceptible. I also wanted to point out that for ESBLs, our various genes have various substrate specificities. So you don't have to have all your third generation cephalosporins showing up as resistant in vitro. So if again you're somewhere where you're not getting a lot of laboratory support, you see a report on the right where the ceftazidime appears susceptible in vitro and it was sent out to you. There was no report of a phenotypic test being done for ESBLs. Once you see reduced susceptibility to any third gen cephalosporin like ceftriaxone, and then you're also noticing the second is affected, you know, resistance to ampicillin, they are seemingly susceptible to the clavulanic acid, and ESBL as a possibility should still be borne in mind. And if it is a serious infection, like the one on the left, which could be, you know, this one is a bloodstream infection, both bottled within 24 hours. A drug of choice would be carbapenem, like meropenem. All right, if it's urine and other antibiotics are tested, so something like nitrofurantoin can be used for cystitis, not pyelonephritis. You know, if you have no other choice and you must use a fluoroquinolone, if they're susceptible, those are options as well. The report on the left looks more like what we discussed previously. This report for 1 liter dose from the blood would be what you would see for your AMCs where you're getting resistance to the augmented. But I want to point out that you can actually have persons co-harboring enzymes, and we've actually done studies on urinary tract infections, and we've seen where this happens. It's not common, but it can happen. And so even though the antibiogram looks more like that of an AMC, it doesn't mean an ESBL is not present. But thankfully for both our AMCs and ESBLs, the drugs of choice for a serious infection remain the same, and that's your carbapenem. So we have, the carbapenems, they were our rescue drugs, but then came the problematic carbapenemases. Just to remind you, in our classification, they fall in a number of classes. So we have a structural classification and a functional classification. I'm not going to get into it, but I want you to note the classes because some of the newer drugs are going to be class specific. So if you hear or you see that there's carbapenem resistance, it now becomes important for you to know what's the underlying mechanism, and if it's a carbapenemase, what's the class. Find out from the lab what's the class, so that you know what your options are in terms of reaching for novel therapy if it's not available locally. And I included this slide for Pseudomonas because although I'm focusing on the beta-lactamases as one of the main mechanisms of resistance in gram-negatives, we know that there are different methods. These are the four main methods that organisms use to become resistant. Drug inactivation is just one through enzymes. We can have target modification, impermeability, or efflux. And pseudo is a good example because there've been reports of use of mostly 3, possibly target modification as well, methods that can result in carbapenem resistance. And the way that this unfolds is interesting because when it's a carbapenemase, all your beta-lactam antibiotics would be rendered useless. Certainly those that we have here. And in terms of your carbapenemases, it's not specific to a single carbapenem. All of them would be at risk. When it's impermeability, it's specific to imipenem, and you see meropenem as being susceptible on the report. And when it is efflux, it's specific to meropenem, so meropenem would be resistant and imipenem would be susceptible. And for a subset of isolate studied at the university, few of them, about 10% of them had carbapenemases, interestingly. So we found a lot of carbapenemases in Acinetobacter, and we've been noticing an increase in the enterobacterial, but not so much as Pseudomonas. We reported a lot of efflux in Pseudomonas, but the good thing is if there's no foreign mutation, oftentimes the imipenem is available. So we mentioned that we have different classes of our carbapenemases. There have been some novel drugs that have been put forward. These are just some that are available. Unfortunately, as far as I'm aware, they're not yet available in Jamaica, but you can try to source them for your patients, or we are also trying to get them on the formulary at the university. But you have drugs like heptazidime avibactam, only covers your class A carbapenemases like KPC, and they're mainly marketed, it's mainly marketed for use in urinary tract infections and intra-abdominal infections. Your meropenem avibactam has a slightly broader coverage in terms of what it can be used to treat. Can also be used to treat your hospital-acquired pneumonias and your bloodstream infections, but again, it's only for class A carbapenemases. Also for class A carbapenemases is your imipenem silastin relebactam. This one though can potentiate seizures, especially if there's an underlying issue. So we're seeing then beta-lactams being combined in these 3 drugs with newer beta-lactamase inhibitors. The older beta-lactamase inhibitors, like clavulanic acid, like tazobactam, would have had no activity against their carbophenamases, but these newer beta-lactamase inhibitors do. Not a panacea, because they don't cover all classes and they don't cover all types of infections. Although sometimes when you're desperate, you will try what you have. You know? You have some newer aminoglycosides like plasmamycin. Plasmamycin's not, there's no specification of the class of carbophenamase that it can be used against, but mainly marketed for UTIs. There's cefiderocol, which is a neocephalosporin, but more potent, which can be used to treat carbophenamase producing organisms. It can be used to treat all classes, has anti-pseudomonal activity, so that's pretty good, and it's one of the ones that we want to reach for. But there are not many like this. And fosfomycin is not a new drug, but it has been shelved somewhat. It has grandfathered back in and is being used for urinary tract infections. So we mentioned post-COVID, some of these bugs we've seen, certainly for eosinophils and some of our carbophenamase-resistant bugs, an increase. We discussed recognizing them, treating them, and so on. We're going to look at some of the other organisms in our urgent and serious threat levels, just to make some comments where necessary on some of them. So our drug-resistant Candida auris, is a problematic organism because 90% of the isolates are resistant to at least one antifungal. And already we don't really have a lot of antifungals available at our disposal. So this is a problem. It was first discovered in Asia, but it has quickly become a cause of severe infections around the world. And certainly in the United States, you can see here that there's been a significant increase. This is a patient, if you get a patient with Candida auris, you definitely want to put them in vary nursing as soon as possible to try and contain this and laser the lab to see if there is anything that can be used to treat it. But again, this one is often multiply drug resistant with few options remaining for therapy. In terms of our own experience with Neisseria gonorrhoeae, Dr. Antinga led a study. I think he mainly looked at isolates from the university and comprehensive with the team. And we did not have any cephalosporin resistant Neisseria gonorrhoeae, which is comforting. So our ceftriaxone remains quite useful, and we do need to preserve it, but we need to consider continuous surveillance for the emergence of any cephalosporin resistant strains. We are able to isolate and do susceptibility testing for Campylobacter at the university. This drug-resistant Campylobacter is not yet a problem, but yes, we keep it on our radar. And happy to report that at the UHWI, they're hoping to start antifungal susceptibility 2 soon, and so that we're better able to monitor our resistance patterns, those that we're seeing among our various Candida species. Also wanted to share our experience with C. difficile. It would seem to us, certainly at the University Hospital, that there has been a slight uptick in the number of cases of C. difficile that we're seeing. And interestingly, we're seeing more cases come in from the community. So we're wondering if these patients may have been at other institutions and then they came to us, or if we're also getting an increase in the number of cases in the community, just generally speaking. So there was a retrospective cross-sectional study done on about 250 isolates obtained from hospitalized and adult pediatric patients at University Hospital. We're able to do PFGE to see if the strains were part of an outbreak, as well as other molecular analyses looking for hypervirulent strains. And we were able to do some susceptibility tests. The study population were from multi-ethnic backgrounds, of course, largely Afro-Caribbean, with 36% being over the age of 60 years. All isolates were found susceptible to metronidazole and vancomycin, which is good. I believe it was a vancomycin, though, whose MICs are close to the borderline, so we need to be careful, but they were all susceptible. all were resistant to Cipro. And there were some other antibiotics tested where we had some varying degrees of resistance. And what this means is that when we use these drugs, they're more likely to leave the C. difficile behind so it can proliferate. Having said that, any broad spectrum antibiotic when used can select for C. difficile strains. So we just need to be careful in terms of how we use our antibiotics in general. The North American pulse field gel electrophoresis NAP type 1 strain was discovered for the first time in our Caribbean population in this study, as well as NAP6 and NAP12. And so one of the things that we were wondering was, when we had very low rates of C. difficile, it was either that one, we were not testing enough, or we didn't have this hypervirulent strain. Now that we're seeing an uptick, we definitely want to do some further studies to see if it is that this hypervirulent strain is what has gotten a bit out of control, so to speak. I'm saying that loosely. We're not having as serious a problem as that reported in North America, but we as a team need to come together to make sure that we are containing these cases by nursing these patients appropriately. The NAP1 strains were the most resistant and were all identical, suggesting that they were part of an outbreak or endemic strain. So our take-home points are that Jamaica and the world continue to see an increase in multi-drug resistant organisms. And on the right, we see the ones that are of most concern grouped into these 3 hazard levels by the CDC: concerning, serious, and urgent. Some for which we have data, have been increasing post-pandemic as well. So this is something that we definitely need to take in hand. And we have therefore emerged and emerging superbugs as shown on the chart. So these are on the right, my references, and I'll be happy to take any questions that you have this time.
Sure, in-house.
Thank you, Doc. Thank you, Doc. Very exhaustive and comprehensive lecture. I think one of your senior colleagues about 2-3 years ago gave a lecture on the tsunami of antibiotic drug resistance. You know your erudite colleague, right?
Yes,
it was very depressing at the time, and mentioning that there was a dearth in research and development of antibiotics. I'm very happy that you're reporting some new fellows on the block here, and hopefully one of these can also knock out the resistant gonorrhea. I don't know, one of these. I've taken a picture of your slide. What is this? Memvaborectam, right? How do you pronounce that?
Meropenem vapobactam is how we pronounce it.
Meropenem vapobactam, and all those things. Any of those effective against the resistant gonorrhea?
No, that's a problem. Among the various novel therapies, they are not, put forward for the treatment of gonorrhea. Most of them, they are mainly for UTIs initially, and then there were some that were developed for intra-abdominal infections, and they expanded some to bloodstream infections and hospital-acquired pneumonias. But the problem is for gonorrhea itself, there's still not a lot in terms of available therapy. They've tried strategies like recommending combination therapy. So they've added the azithromycin to the ceftriaxone as one strategy, but there's not a lot. There's still a dearth for gonorrhea.
Right. And any of these new drugs, will they be available anytime soon at some reasonable rate? Or will you be advocating with the Ministry of Health to subsidize those that would help you?
Good question. They're often not reasonable. Let me start with that. A lot of these newer drugs, unfortunately, because for some of our gram-positives, we've been able to get drugs like linezolid. Tigecycline has activity against MRSA and VRE and gram-negatives, but unfortunately, we're not seeing it perform very well when the organism is drug resistant. It's often resistant as well. And that one runs like on average $100,000 for like a 10-day course. And that's the ones we already have. So I suspect that some of these new ones are going to be expensive. But we've certainly, through my senior colleagues, we've been discussing with the pharmacists at UWI, getting it certainly for the university. I would not be able to speak about what will happen nationally, but I would be willing to discuss with colleagues who may have influence getting those in. We definitely don't need to have more national policies in terms of antimicrobial stewardship policies and guidelines. And we would want to have those drugs just readily available without a counter signature. That I think would need some policing just to preserve its life.
Hi, Dr. Thoms-Rodrigues.
Right,
Just to ask, and we're continuing on the same line that Dr. just started on STIs. So a lot of your data in terms of the drug-resistant gonorrhea is in the US, correct?
Yes, minus that single study I had mentioned from Dr. Anzinger and colleagues as a part of that team, where we had looked at some isolates from comprehensive and the university. Unfortunately, it wasn't an island-wide study, but thankfully, we had no reports of cephalosporin resistant gonorrhea at the time.
Which is where I was getting, because I know that they said locally, either one, we don't have the data, or two, we haven't seen it as yet.
Right.
So I have to be careful that we are sounding the alarm bells in Jamaica as yet. Not to say it won't get here.
Right.
But in the event that it does, we've always been told, reserve the quinolones for later down. There is the option, yes, we know we're supposed to dually treat gonorrhea and chlamydia. So there's the option of adding the azithromycin. Then we hear that azithromycin has issues with resistance. Then, of course, you can add doxycycline. So my question to you is, if in the event the ceftriaxone resistance gets to Jamaica, azithromycin is also being flagged, what are we going to be left with?
Right. Thank you for that question. One of the things we definitely recommend now, I know that we often go for syndromic therapy.
Right.
Now we're saying test. So when the patient comes, take a sample, send it to us, let us see. So even if you start something empirically, review the results and see if you need to adjust to something culture directive. Although you may have cephalosporin resistant gonorrhea strain emerging, it doesn't necessarily mean that it's going to be a pan-drug resistant strain. So you're right, you may see other drugs like the quinolones, although we definitely want to say the quinolones have a high resistance induction potential. So you want to make sure that you only use it when indicated. But absolutely, if there are other drugs that are available on the formulary that can be used, then you can definitely use one of them. And over time, drugs that will be included on the panel will include our penicillins or tetracyclines, the quinolones, and or cephalosporins. You don't always check the macrolides, but if available. The other thing too is that really and truly we should be using a quantitative method for susceptibility testing for more accuracy, and that's not always available. And I'll just leave it at that.
So I hear you say test, but you know the problem with testing is very expensive
and not always available.
A population-wide approach, which is why we use the syndromic management.
Right.
Be out of the reach of a lot of the persons who are coming in with these infections that need to be treated. So in that respect, we have a real problem, because if you try and send them for the STI quad, they can't even talk about STI 9 and 10 plus. We're talking about an issue that oftentimes will affect the majority of our populace because of the cost of testing. So as you say there, it's like you're a double-edged sword. Yes, you don't want to use the antibiotics that you know the resistance is emerging to, but then what option are you left with when the patient leaves your office, them just fling with the paper because they can't afford the test. So that is the real concern.
Perhaps one of the things you can do, Dr. Rooms, and can help us advocate is, even if we are not able to test every patient, we do a sort of sample. So every patient at a public clinic can get a test done free of cost, because even if we're not able to do PCR, we can do culture. Culture is not as expensive. The only thing about culture is that a good sample has to be taken. It must be put on the plate, preferably versus in a transport medium, and sent quickly to the lab, because the organism dies very easily. But I welcome your help, Dr. Rooms, in advocacy. I I understand the points you're raising. They're valid. I'm not hearing so well.
She said something about sending it to you and getting it for free.
Well, I wish I could say that can be done, but I'm sure we can have dialogue.
Another quick question, Doc. So since we're having this issue with antibiotic resistance, is there any data supporting use of probiotics in managing patients with these type of infections to mitigate our antibiotic dependence?
Thank you. Thank you for that question. I'll be honest by saying that the main place area that I've seen probiotics used is for C. difficile infections. You know, we would have lost our normal flora and we're trying to replace it. I've also seen as a hot topic where they had a patient with a very resistant bug for which they had little in terms of treatment. And it was either that they had used a probiotic or a fecal transfer, but some replacement of flora, and the patient actually recovered. Not saying that I have seen it extensively reported in the literature in terms of its use for MDROs, or that I'm widely read on it, but I've seen definitely where it's a well-recognized use for C. difficile, and there has been some activity, some excitement about its potential use for MDROs, especially when you're left with very little options for treatment.
Thank you so much, Doc. All right, so we have some online questions as well.
Right.
Which antibiotic is most resistant in Jamaica?
Okay, I would say it depends, you know, because you may have, as I told you, penicillin being uniformly susceptible in your beta hemolytic organisms, but most other organisms, I would say, your first generation penicillins, where it would have been an option, perhaps are resistant to that by now. We don't have a lot of rates of MRSA. So in terms of our second generation in staff, as we finish out the discussion on penicillins, that's not so high here, but more so in our gram-negatives, more often than not, you know, your penicillins don't do so well. And with the emergence of the ESBLs2 and the AMCs, and the thing about the ESBLs is that even though they are susceptible to the beta-lactamase inhibitor, can't use the amoxicillin with the clavulanate for serious infections because you can have overproduction of enzyme. I will say that we don't have as much resistance to our carbapenems, but that is emerging. The ESBLs are on the rise for sure. So that's going to affect our, not just our third generation cephalosporins, but our second or first or penicillins. Drugs like the aminoglycosides, which are not used as much polymix in the, some of our tetracyclines are the most spared. And I'll leave it at that, but it really does depend on the organism.
Thank you very much.
Thank you.
I'm not sure the context, but the question says, what do you suggest for developing countries where there is no prescription policy?
Thank you. Good question. I think that, excuse me 1 second. Sorry about that, it's the runs. All right, for our territories without policies, we need to get those policies. I think that the problem is so serious that we need to have advocacy and get policies going. I know, like in Jamaica, Dr. Nicholson has been pushing for national guidelines, for national antimicrobial stewardship policies, and there are people within the ministry, they have been meeting, they have been discussing. So hopefully where it is lacking, it will come on board soon. But outside of that, 2 individual institutions can do their own policy. So until it becomes a national policy, if you're in your own institution and you can get your hand on some sort of guideline, you can institute your own sort of policies in order to help in the fight.
Okay, thank you. Last question I'm seeing. What has been your experience with antibiotic resistance in the pediatric population at UHWI?
Okay, thank you. That is sort of sad because most, I may not be too I don't want to be sensational, but you know, in the pediatric population, normally you would see very sensitive bugs, very sensitive organisms. You get away with things like ampicillin and genta and so on. The problem is that, you know, they're not living in isolation from adults. So even at birth, now we see where mothers who are colonized with drug-resistant bugs, they can pass it on to the baby during birth. And so we are now seeing ESBLs in babies, in young children. I mean, all of the various types of resistance mechanisms that we would have described in adults, we are now seeing in the pediatric population, unfortunately. I get a general feel, I haven't studied it, that this is not as common, but we are seeing it. We're seeing it more and more. And so the pediatric population is not spared.
Thank you so much, Doctor. Thank you. So, ladies and gentlemen, boys and girls, for those who unfortunately had to miss their Sunday service, your pastor, of course, you'll have to make amends with that. But we're at the end, and so I'll now, before we finally close off, I'll ask the president of the AGPJ, Dr. Donald Gordon, to come and give us a vote of thanks.
Thank you very much, Nakia. Good afternoon, my colleagues in the audience and online. It's my sincere pleasure to deliver the vote of thanks for this excellent hybrid scientific webinar on antibiotics hosted by Sandoz. Special thanks to our speakers, Dr. Marsha James, Dr. Bridgewater, Dr. Pate-Robinson, and Dr. Rodrigues. We can all agree that our speakers gave an excellent scientific overview and discourse. In their various presentations, which covered the management of the various clinical conditions, the choice of appropriate antibiotics, the avoidance of the pitfalls in the use and overuse of antibiotics, and the burning topic of antibiotic resistance. It was indeed a very hard-hitting presentation by all the speakers. To the Sandoz team, thanks to the Sandoz team for their sponsorship, chairing, moderating of such a well-organized meeting, which was chock full of knowledge, and yet managed to finish on time for us to go home to our Sunday lunch. Thanks to Oldgate Solution for their usual flawless technical support in producing a high quality and technical production free of glitches. Thanks to the AGP support, Secretariat managed by its very able Secretary Lynn for all the hard work behind the scenes to pull all the various elements of this meeting together. To the Pegasus Hotel staff, thanks for the very comfortable accommodation and the refreshments provided throughout the meeting. Finally, to our audience, both online and in person, for your attendance. Without you, the meeting could not have been possible. We thank you once more for your participation and very engaging question posed in the question and answer period. We thank you very much and we wish you a safe trip home, those of you who are in the audience. Thank you.
Thank you so much, Dr. Gordon. All right, so just some final notes, housekeeping matters. And of course, we will allow you to enjoy some of the sumptuous and wonderful lunch that will be provided. However, let me just make one quick announcement. So Sandoz, as you know, we're not just an antibiotic company, even though we are very well known worldwide. So we want to also use this opportunity to introduce you to a promotion that we have going on currently. So we actually have a promotion in our pharmacies where you can prescribe pretty much any of our cardio line products. So that includes our rosuvastatin, our Tensiba, which is our irbesartan, Safe Bull candesartan, and our newest kid on the block, which is a Divinis. And your patient will actually get a month free supply of any of those products. So this is like Christmas coming early, right? So we just wanted just to announce that because there is, of course, benefits to be had there. With that out the way, thank you all for coming. For those who wish to partake in whatever we have available here, you can definitely stay back and enjoy. For those at home, do have yourself a wonderful Sunday dinner. I wish you were here, but next time. And with that said, we're out. Thank you all.
Split.